Welcome, everybody. Thank you all for coming. We're very excited about this afternoon's presentation. We have some outstanding speakers. Our goal today is for this to be educational as well as a way to connect with others who may be going through something similar. I'm Paula Landman. I'm the nurse navigator with the Melanoma program.
And I'm Trish Long, nurse practitioner with surgical oncology with the Melanoma program.
So a couple of housekeeping things. In your folder, you have a survey. We really encourage you to fill it out because it helps us to plan for next year and to understand what we've done well and what we can improve upon. I want to give a special thank you to the Melanoma Research Foundation for their financial support and logistic support and emotional support. Also, Donna Cavallo is our administrative assistant with the oncology program. She's been an enormous help. I also want to introduce two folks here that are really key to the program, and many of you have spoken to them on the phone, and they are the welcoming voice in a very scary time. Patty Roten, where are you hiding?
Stand up.
Stand up. And Kim Anderson. They are our intake coordinators, and they are the people that you first meet, and as I said, during a very scary time, they do a million different things to help our team here.
Behind the scenes, for
Yep.
sure.
In our gathering here, we have many patients who were previous speakers in other years, and they're still doing beautifully, and they come to support us, so I'm going to embarrass them and have them stand up so we can give them a big cheer. Miss Edmonds, up. I know you some. More people are here. Miss Mazurko. Where are the Jacksons? Dr. Jackson, up, up, up. So we've made a lot of strides in melanoma treatment, but unfortunately we have had losses, and we can do better. I just want to take a few moments to think about folks that we have lost to melanoma or to for any other reason, and just hold them in our hearts for a moment of silence. Thank you. So our first speaker is Kylie Lapira. She comes to us from Washington, D.C. to be with us today, and she's the CEO of the Melanoma Research Foundation. We're very honored and appreciative of her being here, and she's going to tell you all about this amazing organization.
Well, thank you all so much for allowing us to be here. I was asking Paula earlier how many years we've been doing this, and it's been for over 10, at least, probably closer to 15. So it's great to see so many of you here and interested in learning more about, what's on the horizon, and you get that intimate access with your clinicians and other doctors, and I think it's wonderful. And you have a new rock star joining UNC, Dr. Laura Ferris, who I'm thrilled to introduce in a few minutes, but Dr. Ferris was on our board as of late and is now heading up the Department of Dermatology here at UNC. So you have a new rock star in your midst. I just wanted to spend a couple minutes giving you a little bit more information about the Melanoma Research Foundation and the resources we offer, who we are really. But before I do that, I really want to thank our sponsors. All of the programs we host around the country, in fact, we held our Seattle Symposium on Saturday, are fully funded by our corporate partners. So we're able to have you all come here and put on a nice event for you all at no cost. So we're very grateful for all of our support from our corporate partners, and many of them are here today too. So if you meet one of them, please thank them on the break. So I want to give a little bit of an overview of the foundation. We are 29 years old, and we're based in Washington, D.C. I was telling my lunchmates the brutal commute I have every day into our nation's capital. But we were founded 29 years ago by a patient who was dealing with her third recurrence of metastatic melanoma. And unfortunately, at that time, there were very few treatment options available. In fact, there were only 3 FDA-approved drugs to treat metastatic melanoma. So it was a very bleak time. And unfortunately, there wasn't the investment from the federal government in melanoma research either, because there were such poor outcomes, there were not a lot of researchers who wanted to go into the field at large. So a young woman by the name of Diana Ashby in a small town in Virginia decided to start fundraising and to support melanoma research. And that's exactly what she did. She founded the foundation, and in 1996, we gave out our first research grant. But as you can all attest to, melanoma research has advanced, and what we realized was that we not only need to fund research, but we need to educate and empower patients and caregivers and give them the information they need so that they can make the most informed decisions about their care. So the second part of our mission is education, and many of you picked up the education materials that were on the desk right out front. Those are all free. They're also available through our website where you can order them online and we'll ship them to you, or you can take them to community events or to your doctor's office for their waiting room or your children's school. But they're great resources, and they create a lot of awareness about melanoma and melanoma prevention. And our footprint today is a national one. So although we're based in Washington, D.C., like I mentioned earlier, we are in communities all over the United States, and our advocates are doing their own work in communities as well. They're hosting their own community event, or they're speaking on a panel, or they're talking to their children's school about the use of sunscreen. So I just wanted to touch a little bit on our 3 pillars that I mentioned earlier. So our first is research, and I think there is so much need right now to highlight the importance of research and the need for patients to have more options. So to date, we have funded over $26 million in peer-reviewed research to academic institutions all over the United States. These have resulted in FDA-approved drugs, patents, additional grants and funding, and has really helped benefit patients directly. We also host scientific meetings, so while we're at a patient meeting, we do the same but for our scientific community on issues that are relevant for patients. So for example, we're doing our 4th workshop with the medical community on brain metastases this fall. Education, as I mentioned earlier, all of our materials are free. We also host webinars. Many of you may have attended a webinar in the past. We have these on a variety of topics. We have a series called Ask the Expert, where you can learn about a specific topic with clinicians and researchers, as well as patients and caregivers. And we also have a lot of education on our rare subtypes, our uveal, acral, mucosal, pediatric melanoma. And again, this just kind of gives you a snapshot of some of our education materials. We have over 26 pieces of literature, and we're coming out with some new ones as well, which I'm really excited about. We have a 0 to 1 patient guide, a 2 to 3 patient guide, and 3 to 4 patient guide, all with supplemental caregiver guides. So we're going to be shipping these out very, very soon, and they're going to be a great resource for patients. Our animated melanoma patient videos, I'll just highlight for 1 second. So these are 6 to 8 minute animations that explain very complex topics in about a 6th grade reading level. So these are great for patient waiting rooms. They're wonderful for children's schools. They're just great for everyone to learn a little bit more about a specific topic. So there you can see we have understanding melanoma, treating melanoma, diagnosing melanoma, and then we go into very specific things like TIL therapy. Here's where you can find our educational videos. All of these are on our YouTube channel, so you don't have to go searching. They're all right there. If there's a specific topic, you can go right to YouTube and search. I mentioned our Ask the Expert series earlier. Again, we do these monthly on various topics. And our patient and community forum, I think this is a huge resource for patients. So this is on our website. It's a peer-to-peer patient forum. So people will write in and say, I'm having an adverse reaction to X. And someone will say, oh, I did too. You know, this is what my doctor told me. And it's just a way to connect with patients. I think it's a great resource. Patients find a lot of comfort in it as well. And many times they will bring things that they read on the forum back to their doctors. Our advocacy work, we also spend a lot of time on the Hill and talking to lawmakers about issues that impact the melanoma community on a federal level, but we also interact with lawmakers on the state level as well. We always have calls to action where we can mobilize our advocates to talk to their lawmakers on issues. And there's no shortage of issues these days, it seems, but one of the things that we're really fighting for is melanoma research through the Department of Defense. So we are very happy to report that the funding that we got through the Department of Defense, the $40 million, has been preserved for FY25. And a lot of that is thanks to the advocates who met with lawmakers and told them their stories about how research saved their lives, whether it was a clinical trial or it was a drug that was developed from a clinical trial. And that really does make a difference. So every March, we bring our advocates to Washington, D.C. to share with them the importance of funding research to benefit the melanoma community. I just want to highlight our prevention awareness campaigns. Again, we spend a lot of time educating the public about melanoma prevention. We have a campaign that's called #GetNaked, where we feature somebody who wants to share their story about how they found either a spot on their skin or how they do self-skin exams because they've been personally impacted by melanoma. So Raheem Mostert, who was the running back for the Miami Dolphins, he just recently left them, but his life was impacted by melanoma because his coach and mentor passed from the disease. So for him, it was very important that he gets the message out about checking your skin and advocating for sun safety. We also have campaigns for our uveal melanoma called I Get Dilated, as well as our pediatric melanoma and mucosal melanoma. We also have some very special programs, which I'll just briefly touch on, that I'm very excited because our Breakthrough Consortium UNC is now a part of. This is a think tank of the brightest minds in melanoma who come together to work on cross-academic center research projects to really accelerate cures for patients. So it's a really exciting initiative, and we're thrilled that UNC has now joined that think tank, and I think a lot of good will come out of it. We also have a focus in our rare subtypes, which I mentioned earlier, one of them being mucosal melanoma, which again is a very rare form of melanoma, but there's not a lot of research in the area and there are very few options. So we brought together a group to help accelerate research in that area as well. And many of you may have picked this up, but we just have featured an ad in Cancer Today, which we're very excited about. Look for our ad. Again, it gives people access to free educational materials, which we feel is extremely important. So with that, I will turn the show back over, but I do want to make sure I let you know how you can tag us on social media. If you hear something great today that inspires you, share that out and pay it forward, because there's a lot of people who want to be in these seats learning about all the great things that are happening, and you can be a catalyst for that as well. So with that, I will turn it over to Dr. Laura Ferris, who recently joined UNC as the chair of dermatology here, and I will let her take it away from here.
So thank you. It is such an honor to be here, and it's wonderful to have sort of my two worlds collide of the MRF and now UNC. So thank you. I'm looking forward to speaking to all of you and really excited to be part of this team.
Sorry, let me see if we can figure this out.
I'll do much better with my own slides, definitely.
All right, where did my little mouse go?
There we go.
There we go, and from the beginning.
Great, perfect, yes. Great, okay, so I thought I would talk about melanoma kind of from the perspective of what your dermatologist wants you to know. A lot of times, we're always part of your care team, but we're oftentimes the first people who make your diagnosis and who have to present to you this, unfortunate news and also your plan moving forward. So these are things that have often come up as patient questions. So, how do we diagnose melanoma? One big thing that comes up is what do all these things on my pathology report mean? What are my next steps? What does the future hold? And then how can I protect myself from melanoma in the future, and also my family from melanoma and skin cancer in general? So most of you have probably learned about the A, B, C, Ds of melanoma. So these are the kind of things that, these were developed to be an easy to remember, easy to educate on set of criteria for identifying melanoma. So A, asymmetric, B, borders that are irregular, C, colors, meaning multiple colors, and then D, diameter of 6 millimeters or more, or I say bigger than a pencil eraser. And then we really talk about E, which is evolving or changing, which is incredibly important. I put on 2 other things. One is regression, which is an area that used to be black or dark brown and becomes whiter than the surrounding skin. And then one that I actually think is super important is the ugly duckling sign. So, most of us remember hearing this, but it's really that one, reading this book as a child, but it's that one mole or spot that just doesn't look like anything else on your skin. These are all good warning signs. And, I always say making a melanoma diagnosis, sometimes it can be easy. I think everybody in this room would look at these and say, that doesn't look good. But, these are also melanomas that were much more subtle. So, it's really important that we really keep studying and learning about how to make a correct diagnosis early. And then I like to put up this slide. These are all melanomas on this slide. They all look different. Some of them follow the ABCDs. Some of them do not. Some of them are in areas like nails that we might not think about as being typical areas to develop melanoma. We've got one that's amelanotic or pink, so it doesn't have the black-brown color. So, the ugly duckling, these are really things that didn't look like anything else on the skin. That's an important sign. Okay, so how do we make a melanoma diagnosis? Well, we do a skin biopsy. So, there's a few basics that are important to know. So number one is, if possible, remove the entire lesion. And when we talk about the pathology report, I'll go over why that matters. So there are different ways that your doctor can do this. So, one is, and one of the most common things that we will do is called a saucerization or a shave biopsy. So in medicine, when we talk about a biopsy, sometimes we just mean taking a little piece of something to say what kind of cancer is that, or to get more information. When we talk about a biopsy of the skin to diagnose melanoma, what we really mean is trying to remove the entire lesion if possible, so we can get all the information we need to appropriately diagnose, stage, and come up with the next plan. Other ways that we will sometimes do this is an excision, so an elliptical excision where we cut out with a little, a couple millimeters of normal looking skin on either side and sew it up. And then another way is sometimes your doctor may use what's called a punch tool to do a punch excision. Again, it looks like a little mini cookie cutter, and what we're trying to do is get the whole thing off. So we want to get the whole thing off in terms of laterally, looking at the edges, but also deep, to see how deep into the skin it goes. Okay, and why do we need that whole thing? Because when we get a melanoma diagnosis, I'm not just saying, is this melanoma, yes or no? I'm trying to get a lot of important information, and this all ends up in the pathology report, which now with access to your own records, you're oftentimes going to see, and even sometimes you're going to see it before your dermatologist does see it if it's released on. So I like to kind of go over what's in here, because it also helps set the stage for some things you'll hear about later. So one of the first things that we'll look for is, what subtype of melanoma is this? And I'm really mostly talking about cutaneous or skin melanoma. So the most common one is superficial spreading melanoma, and that is going to have the best prognosis. But sometimes patients have read that and said, I saw that I have spreading melanoma. Well, it's not the same as spreading throughout the body, so I think that's important. And then there are other types that can be more aggressive, like nodular melanoma or acral melanoma that's on the palms or the soles. The next thing that we're going to look for is the Breslow thickness. And this is how deeply into the skin can we detect tumor cells. And so thinner is better. In fact, in situ melanoma is what we call a depth of 0. So it has not invaded into the dermis. It's just sitting at the top layer. That has the best prognosis. We talk about patients having thin, intermediate, or thick melanomas. We're generally talking about this Breslow thickness. So less than 1 millimeter, we refer to as thin melanoma. 1 to 4 millimeters, we'll talk about that being intermediate thickness, and then greater than 4 millimeters being thicker melanoma. And then the other thing that you will see is Clark level. This is actually not part of our updated staging, but it is on most pathology reports. If I can give you one take-home message, this is not disease stage. So this talks about which layer of the skin, independent of that millimeter depth, which layer of the skin is the deepest in which we can see tumor cells. So you will see a Clark level 4 melanoma, and sometimes patients will see that and they will say, oh my gosh, I have stage 4 disease. You do not. That is just simply another way of looking at thickness. And then ulceration. So what that means is there any breakdown of the top layer of skin? That can be a sign of more rapid tumor growth, and that can be a sign of a worse prognosis or a more serious melanoma. So why are these important to us? So this is a graph that is looking at melanoma, the probability of still being alive despite having melanoma going out to 10 years. So you can see here that the red line is sort of the least steep, that's the best prognosis, and that is our T1A tumors. So when we look at tumor staging, it's really based on the thickness of the tumor, and what we can see if you match up all these numbers is that the thinner the tumor, the better the survival. So really, that's one of the first things that we go to when we look at your pathology report, to really know what is the prognosis and what is the next step going to look like. Other things that you will see are mitotic rate. So if you go back to like high school science and you think about mitoses or cell division, that's what we're measuring. We're counting how many cells can we see within that biopsy specimen or within a certain area of the tumor that we can see evidence of cell division. And so the more mitoses that we see, the more active that tumor is, and that can be associated with a worse prognosis. You'll see sometimes mention of satellite metastases. This means basically microscopic small nests of tumor cells that have broken off, and we're really saying, can we see them or not? Sometimes we'll see reports of tumor infiltrating lymphocytes. Not always. So these are basically your white blood cells, the immune cells, and we're trying to see, can we see them attacking the tumor? If it's, and you may see absent, non-brisk, or brisk. A brisk TILs, or tumor-infiltrating lymphocytes, can be a good sign that your immune system is kind of already on this tumor and fighting it. And then regression, which is what I talked about in that ABCD section. This is, can we see areas where we see scarring, where there used to be melanoma cells and now there's not? And that's, again, generally a sign that the immune system is fighting off the tumor. It can also mean that what we're seeing when we measure where we see tumor cells might not be totally reflective of the original thickness. So why do these matter? Mitotic rate and satellite lesions, you can see again here, 0 mitoses is that red line. That's the best melanoma-specific survival. When you get to 11 or more, the brown line, you can see that the prognosis becomes worse. So this factors into our counseling and decision-making. And then satellite lesions, red is if you have none. And then the other colors are sort of different variations on satellite lesions. But you can see patients who have none do better than those who do have them. Okay. Lymphovascular invasion. So this is saying, can we see tumors that are invading into blood cells or lymphatics? And we report this as present or absent. If it's absent, that's a better sign that the tumor is not sort of going into the way that tumors can spread through the body, or either through blood vessels or through lymphatics. And so we'd rather not see the tumor already invading those channels. Perineural invasion is, can we see tumor invading some of the nerves in the skin, which can also be a worse prognostic sign. And then sometimes we'll see, did the melanoma, was it occurring in a pre-existing lesion? So did this develop in what was a normal mole, or did it develop sort of in otherwise the absence of a mole? And then growth phase. So sometimes you'll see this, which is radial, which means its growth phase is going out, versus vertical, which is the tumor is growing down. We prefer to catch melanoma in the radial growth phase, not when it's moving, not when it's going deeper, because we know that that tumor thickness is associated with greater thickness, worse prognosis. Okay, just a real quick overview of what is staging. So if we say you have stage 0 melanoma, that's melanoma in situ. Stage 1 is melanoma that is thinner melanoma, basically, with just less than a millimeter of invasion into the dermis. Stage 2 can be melanoma that's either thicker or ulcerated, so a lot thicker and not ulcerated, or a little thicker and ulcerated. Stage 3 is when melanoma has spread to the draining lymph nodes. And then stage 4 is when we see spread beyond the lymph node basin and into either distant lymph nodes, or organs like the lungs, the liver, et cetera. Okay, so what happens next? Generally, one of the first next steps will be surgery of some sort. Not always. We'll talk a little bit about sort of some of the new paradigms of how we treat melanoma. But if a patient has melanoma that is either in situ, so hasn't invaded, or is thinner than a millimeter, and I'm really going to say thinner than 0.8 of a millimeter. Oftentimes that is something that will be done and taken care of in your dermatologist's office. Why is that? That is melanoma where we don't do additional staging through sentinel lymph node biopsy for most of these tumors. So we will, that can generally be treated with surgery alone. Depending on the size and location, your dermatologist may be comfortable doing that in the office. For some, depending on the dermatologist, the location, the size, that may be sent to be done in the operating room with the surgical oncologist. And then, or for what we call Mohs surgery, or really what we're talking about here is a procedure where we can go and actually map the periphery and the depth and make sure that every bit of tumor is removed. This is really only done in certain specialized indications or settings. We don't do this for every melanoma, but if, for example, you have what we call anatomically constrained area, a large but thin melanoma that is, abutting near the eyelid, or near the ears, or on a digit that, we don't want to remove a finger for this melanoma. We may do this procedure to map it out. But for very large for very thick melanomas, we don't do this because in general, patients are going to be going for a sentinel node biopsy. And then this is just a little bit of follow-up. So this is using NCCN guidelines. These are the guidelines. They don't just exist for melanoma. They exist across all tumors that help guide us in the next step. So, what part of this is your dermatologist going to want to talk to you about? One is if we look at or melanoma in situ, stage 0, the recommendation from the NCCN is that patients who have melanoma in situ should be getting an annual skin examination, really to make sure that that melanoma, once it's treated, doesn't recur, and because we know your risk of getting another melanoma is higher once you've had one. But there's really no routine blood tests or imaging, so scans. So we're not going to say you need a chest x-ray or you should get a PET scan. If you have stage 1A to 2A that we think has been cured surgically, then in general, we're going to recommend a skin exam every 6 to 12 months for about 5 years, and then once a year, really generally for the rest of your life. At this stage, we don't typically recommend blood tests or scans either. My oncology colleagues will talk a little bit about what kind of imaging and when we would do that. So other questions that come up. Should I tell my family to see a dermatologist if I've been diagnosed with melanoma? Having a parent or sibling with a history of melanoma is associated with an increased risk of developing melanoma. Now, that risk is not equal across everybody. So if your great aunt had melanoma, the risk to you is much less than if your mother had melanoma, for example. So we talk about first-degree relatives being parents or sibling. If that family member developed melanoma when they were younger than age 50, that would suggest that there was potentially not just sort of a sun exposure risk factor, but maybe a genetic risk factor. So I really stress this particularly when the family member was under 50. And so I would, talk to your dermatologist about, how much genetic risk or familial risk there is, and who in your family should be getting screened. Only about 2% of melanomas are associated with known familial melanoma syndromes. So these are rare, but there are 2% of our patients out there. These individuals are going to be followed very carefully, usually at least every 6 months. But these are generally people have had genetic testing, and we know that they possess a gene mutation that does make them more likely to develop melanoma. One thing that also will come up is, should I tell all my friends to go see a dermatologist for a skin check? And so the United States Preventive Services Task Force is the group that reviews all the data for things like cancer screening, so things like mammography for breast cancer, and they have given us a grade of I, meaning that we have insufficient data to say that we should be screening the general public for melanoma. So that does not mean people who've had melanoma. It doesn't mean people with first-degree relatives. It doesn't mean people who've had other skin cancers, but just the kind of general public, your next door neighbor who doesn't have a family history of skin cancer. At this point, it's not recommended that everybody go get a skin check. Okay, what is recommended is preventing melanoma. So, people will say, how do you know sunscreen works? And this is one clinical trial that I'll show because I think it's really, it's very simple to understand and it makes a lot of sense. So this was in Australia where the rates of melanoma are very high. They had 812 patients who were, half of them were given sunscreen and told to apply it every day to their exposed skin. The other half were just said, do whatever you normally do for sun, for sun protection. And what we can see here is that the group that got sunscreen is in blue, and the group that was just told do whatever you normally do is in yellow. And we can see that their number of new melanomas is significantly lower in the group that used sunscreen. In fact, sunscreen reduced the risk of melanoma by about 50%, and it reduced the number of invasive melanomas by 73%. So this was really good data that we can prevent melanoma. And then with sunscreen. And then this is just comparing prevention to early detection. And this was modeled, and this looked at, prevention meaning daily sunscreen use, early detection meaning whole body skin exam by physicians annually starting at age 50, and no intervention was just, not doing either one. And this was modeled based on data, partly from the study that I showed, but some other studies in Australia. And so compared with early detection, so people just getting an annual skin exam, the prevention arm of sun protection was associated with 44% fewer melanomas, 39% fewer melanoma deaths, 27% fewer other types of skin cancers like basal and squamous cell carcinomas, and a 22% reduction in skin cancer-related healthcare costs. So really, prevention is, I cannot stress, the best thing that we can be doing. So, in summary, talk to your dermatologist. We are your partners in this journey. We can, ask your dermatologist if you have questions about your pathology report. If you see a new changing ugly duckling, please call your dermatologist and let us take a look. If you have a family member who was diagnosed with melanoma before age 50, consider that to be sort of the strongest family history risk factor, and first-degree relatives should be screened. Don't forget about sun protection, and I can't emphasize also the incredible value of the MRF website and programs that they have. The Ask the Expert seminars, you can log on and hear like the world's expert give information directly to patients, answer your questions. So it's really, check them out. They're a great resource. Thank you guys very much.
Anybody have any questions for Dr. Ferris? That was an excellent presentation. Okay. Dr. Colicchio here, she is. It is your turn. I'm going to invite Dr. Frances Colicchio to come on up. She is our very beloved.
Do you want them with Bill?
She's our oncologist with the melanoma program, one of our several oncologists here, and she's going to tell us about melanoma treatment and what the future holds.
Thank you, Paula.
Okay. Are you on? I think you're on. I don't know about that.
And I did not ride my bike here. Yay! I'm literally this wet from the bus stop to across the street. So when you guys go outside, it's going to be really cold because the front came in. So Dr. Ferris's presentation is actually a good segue to this, skin. I'm only going to talk about skin for this short presentation. I'm not going to do the mucosal or ocular because too much to cover. And I wanted to remind everybody about the mechanism of immune checkpoint inhibitors. So on the far left side of the screen is the immune checkpoint. This is fascinating, right? This is where something enters your body. It could be a cancer or a virus, and your body knows that it's foreign. And it creates this reaction which then goes to what Paula always says, the scene of the crime, where the virus is killed or the cancer is killed. But, if this happened endlessly, we'd all have rheumatoid arthritis or Sjogren's or some autoimmune disease where we start attacking ourselves. So the brilliant scientists figured out that there's these, and this turns off. And the drugs that you guys often will take for your advanced melanomas are called immune checkpoint inhibitors, or offs to offs, which turns the immune system back on. One is the CTLA-4 inhibitor, which in this country is ipilimumab or Yervoy, and the other one is the PD-L1 inhibitor, which is nivolumab or Keytruda pembrolizumab. So we're going to go stage by stage, and as you notice, I did not include stage 1 or MIS tumors because they're mostly cured in the dermatologist's office. And when you do lectures, you have to make sure you don't use anybody's real name or picture or anything, so you can get these off PowerPoint. So I always tell my students if they can pull the people off PowerPoint, these are people that have generously allowed their photograph to be used. So this is not a real case at all. But we'll pretend. So we have a 45-year-old teacher. She has no medical problems. She has a wide local excision for her cancer, a PET scan that's normal, and she's told she has stage 2C melanoma. Okay? So that's what she's told. And then she sees a medical oncologist, somebody like me or Dr. Muskos, and says, what do I do next? Well, it's actually very complicated in stage 2C, because it turns out that patients with 2C melanoma have a worse prognosis than patients with 3A. So we found out a few years ago that if these patients took a year of a PD-1 inhibitor, such as pembrolizumab, their chance of living longer without cancer goes up. And so we have long discussions with patients about this because we can't tell them they're going to be cured with these drugs. We can just say that you're going to live longer by taking this medicine. But we can also tell them that there could be a lot of side effects, which I know some of you have experienced with side effects from these medicines. So some of the patients will choose to do this, and some of the patients will choose to be followed. So in our fictitious case, she chooses to take the treatment for a year, and she's getting monitored. Okay? So let's move on. Now we have a stage 3A patient. Once again, I made him up. He's 32. He has a nodular melanoma on his back. He has no swollen lymph nodes. He has an otherwise normal exam. He sees a surgeon, we'll pretend it's Dr. Olilla, and he has a wide local excision, and his sentinel lymph nodes are removed. And there were 2 sentinel lymph nodes. One of them has a tiny bit of cancer in it, and he comes to see me, and he has stage 3A melanoma. So stage 3, I'm sorry, stage 3. So he has actually 2 choices. He's a 3B, not a 3A, 3B. And this is also a complicated discussion because he can take that PD-1 inhibitor, nivolumab or pembrolizumab for a year, or since there's this genetic thing in his tumor, not inherited by his mom or dad, but in his cancer called a BRAF mutation, he could take a year of pills. So this is a long discussion with the patient to decide what he wants to do. And as of last summer, these treatments are equally effective in, once again, delaying the onset of cancer reoccurrence if it's going to reoccur. So the patient could be cured, or he's not cured, and if you take these drugs, you might improve your chances a little bit. So if he were to take the pills, we call those target treatments, and he could take dabrafenib and trametinib based on a study called COMBI-AD, or he could take encorafenib and binimetinib, which we often do because those medicines don't cause as much fever. Or he could take the pembrolizumab and nivolumab, or he could choose to be observed, which means CAT scans and exams. So he, let's see. So this patient chose to take the immunotherapy. Now let's take the same case, and now same exact patient, but this time, instead of the lymph node being something super secret and you don't feel it, he actually feels the lymph node, okay? So this is where it gets a little more complicated. He says, I feel this lump in my armpit, and on PET scan, it's a big 2-centimeter lymph node. So instead of removing that lymph node, guess what they do? They take a biopsy and they prove that it's got melanoma. And so this is where there's a difference between taking all the cancer out, which is thus far what we talked about today, versus applying a treatment to a person who has cancer still in their body. So the top is called adjuvant, means in addition to the surgery, and the bottom is neoadjuvant, means going before the surgery, okay? And there's 2 trials that your doctors might throw around with you in the clinic. One's called NADINA, and the other one's called SWOG 1801. And NADINA was the big splash, and last year's international meetings was one of the best 5 abstracts presented over probably about 30,000 abstracts for that meeting. And I'll show you why. I guess I didn't put a slide in that one. But basically, with NADINA, we were able to show that patients who had the treatment before they got the surgery, about 50% of patients had no cancer at the time of the surgery. So they avoid doing a whole additional year of immunotherapy. They could stop with just 6 weeks of treatment. And similar results we're hoping to see in the future by applying a few treatments of pembrolizumab or nivolumab and then doing surgery. But the standard of care for SWOG 1801 is that you keep going on with more immunotherapy. So very complicated if you have stage 3. Okay, so now, I hate using stage, and, a lot of my patients will say, what stage am I, doctor? I think you need to have a little bit of that vocabulary, but sometimes when we use the word stage 4, that's it. That's it. It's Charlie Brown all the way. They can't hear you say anything else. So you guys have to understand that stage 4 in 2025 is not stage 4 as it was in 2002 when I started doing this. We actually can cure some patients with stage 4 disease. So our patient in this scenario is 60. She was diagnosed with stage 2B melanoma. She chose to be observed, and in one of her observation CAT scans, they see some nodules in her lungs. Everything's favorable for her. She has no brain tumors. She does have that mutation on her cancer called that BRAF mutation. So what's she going to do? So the standard of care for her is actually immune therapy. So if you have the option of using immune therapy for stage 4 patients, you do that over the pills, because with the pills, you really can't stop them. They're just something you have to take forever and forever. Whereas the immunotherapy, you can more of a short course and hopefully cure the patient. Okay, this is where we actually are spending a lot of time in our clinic, because a lot of our patients come to us from far around the state or states because they've already been through standard of care and their cancer has come back. So now what? So that's why we send Dr. Moskos to talk to the pathologist and do his high-level thinking all the time. That's all right. It's good music. That and the rain really woke me up. So this one, y'all, is after the PD-1 inhibitors. What is this patient going to do? So he comes to the doctor. He's had ipilimumab and nivolumab. He is found to have a lymph node in his neck, and CAT scans show that there's new disease in his liver too. So there's actually several standards of care for this patient. If the cancer has that BRAF mutation, he can take that medicine. Or they can retreat him with immune checkpoint inhibitor again and see if it works. There was a 6-month gap, so it certainly can. Or there's a combination of pembrolizumab with a really fancy pill called lenvatinib, or the tumor-infiltrating lymphocyte therapy, which is called lifileucel. And to remind you all, because I think a lot of you were here last year, lifileucel is really kind of a technology where for really kind of our very robust, healthy patients who are in a situation where they're running out of great options, the tumor can be removed and then sent to the laboratory I think it's still in Pennsylvania, and these tumor-infiltrating lymphocytes are grown. Then the patient is admitted to the hospital, undergoes chemotherapy to remove the healthy blood cells that are in the body, and put back in the tumor infiltrating lymphocytes that were grown. And interleukin-2 is also administered to augment the immune system. So it's very fancy technology that works really well for some people. And then as we talked about with the Melanoma Research Foundation, heading this up is clinical trials. I would not be here today without clinical trials, because that's where all this stuff came from about 2008 till 2010. We were the ones, the melanoma groups, are the ones that created all of these drugs that are used in every cancer now. So let's push for more trials. This is the one I work with in clinic all the time, and every time I give a talk, people want to know about this virus. This is herpes virus. It causes cold sores. And this one has been genetically changed, so it can't make you sick. And when it goes into the cancer, it causes the cancer to break up and die. And then there's a message given to create a vaccine for the rest of the body. And so every week we're using this in clinic. We're administering it to tumors that we can see or feel. And then if we can't see or feel them, Dr. Burke or someone on her team will administer it by ultrasound guidance. And there's an example of a gentleman that we treated at the beginning of our trials who had a lot of melanoma on the side of his chest wall. He could not take immune therapy because he had myasthenia gravis. It was a contraindication to immunotherapy. And he went 10 years without any cancer after the treatment was given. And then here's another gentleman who I just saw a couple of weeks ago. His melanoma was in his neck, as you can see from that picture, and then also on his kidney. And so what's really interesting of that case is there was no other drugs at the time, and he got TVAC, and he had a nice result in his neck and on the tumor that was on his kidney. This year we have 2 people that have started this trial, Ignite-3, and this is a new virus that we call VO. It was made with the same construct as the herpes virus, but it's a little fancier. It travels better. It's probably a little bit safer. So we're pretty excited about this study. Patients get either doctor's choice, which for us will be a combination of nivolumab and roulette and limnab, or the virus. And when the virus is given, it's given with nivolumab. And then AB248 also opened this year. Fascinating study where instead of giving the patient interleukin-2, which has a lot of side effects, this is a product that makes an antibody that specifically causes the white blood cells that your cancer needs to fight the tumors to grow in the body. So that's why I have a smiley face on it, because it makes it much safer for the patient. So there's a lot. So, stay informed, call Paula often. She doesn't answer today, you know why. And, just be optimistic, because that always helps too. Any questions? No? Okay.
Okay, so next we have Dr. Scott Chen, who is the assistant professor here at UNC in the Department of Radiation Oncology, and he is going to discuss the role of radiation in the melanoma world of treating it. So here we go. Thank you.
Thank you all. Well, for some of you who might have been here last year, some of the slides are the same, so I apologize, but I do try to add some new slides. So, disclosure, and I always like to keep this slide because it's kind of hard for some of you who never met a radiation oncologist to know what they look like. So we know cancers can be treated by surgeons or medical oncologists, and by the way, I'm really glad I'm following Dr. Ferris and Dr. Cliccio today. When it comes to radiation oncologists, possibly this might be the image some of you have in mind. And I'm working up to the attire of Dr. Doc Brown, and I think I have most of what he has, except for the white hairs. I'm working on that front. The goal of today is to learn radiation as a tool to treat melanoma and cancer in general, and discuss how we use radiation to treat melanoma in 2025, and to give you a sneak peek about what radiation oncologists are working on for the future. I'll just move through this slide very quickly because it's kind of boring. Radiation kind of works very on a cellular level on cancer cells in a way that it damages the DNA of the living cells for both cancer and normal cells. And we do still use radiation to treat cancer because there are two reasons that we can sort of damage cancer cells more than normal cells. One is cancer cells are often bad at repairing DNA damage on their own. And the second reason is because modern radiation techniques really allow us to focus radiation on areas that we need to focus on and spare the rest of the body. So the radiation can be given in small quantities or large quantities over several weeks versus just a few treatments depending on the scenario. And we really don't use very long course of radiation very often nowadays with the advancement in surgical and medical oncology treatments. And rarely, radioactive materials can be used to treat localized cancer as well. And this can be relevant in some of the rare melanomas, for example, mucosal melanoma in the genital urinary tract. I also like to keep this picture because this is, contrary to what people believe, this is not the hand of Dr. William Röntgen. I guess he was a doctor himself, but his wife's hand, because as soon as he discovered X-rays, he used his wife for scientific experimentation. The treatment using radiation for skin cancer came shortly after that, and I guess first case of skin cancer cured by radiation was down before 1900s. And really modern radiation technique came after the development of modern medical linear accelerator invented in Stanford and across the pond in Europe that gave us the ability to generate high energy X-rays that can penetrate deep into the body and treat areas of the body that are traditionally not accessible to more superficial radiation. And this, I suppose, was one of the earliest medical linear accelerators that was used to treat patients at all. And this, I believe, was a patient with retinoblastoma, a cancer of the eye, that was treated by radiation successfully at Stanford. And more recently, stereotactic radiosurgery, which is sort of a mouthful, which I will repeat a few times later, for the brain was initially developed in the 1960s by neurosurgeons initially in Sweden, and later on for the rest of the body in the 1990s and 2000s, sorry. And it was estimated that many patients will receive radiation at some point, but not as many for melanoma. Again, this is one of the examples of early radiation treatment machines, which can take probably 3 or 4 stories and very unwieldy and less accurate. Nowadays, we use machines that are much more compact and have more functionality that will allow us to not only deliver radiation, but to see tumor in real time with onboard imaging. If you've seen one of these machines, you know the machine sort of rotates around your body and delivers radiation in many, many different angles. That really allows us to focus the high-dose radiation on the area that needs to receive high-dose radiation. So no, we still haven't developed the ability to turn people into the incredible Hulk, or at least I'm not aware of any. Brain radiation, yes, can cause people to be sick or lose hair. But oftentimes when we use stereotactic radiosurgery for the body or for the brain, it does not cause a lot of side effects, or oftentimes not at all. I did add another question that I've heard in the past from patients that is, can I only receive radiation once? And I suppose there's some myth around that suggests people can only receive radiation one time, but that's not true. With the accuracy of the modern radiation treatment, people can receive radiation oftentimes to different parts of the body, but if necessary, even to the same part of the body safely. In the past, radiation for the treatment of melanoma have been used in many different scenarios. Nowadays, we're more selective in who we offer radiation to, especially in the upfront setting in patients who with localized melanoma. In the past, people with melanoma that have spread to the lymph nodes, we have used radiation to sort of clean up the scattered cancer cells after surgery, but nowadays there are more effective treatments for that that Dr. Cliccio just went over. With the advancement of adjuvant and neoadjuvant immunotherapy, radiation is used less to treat localized melanoma, but more used to treat metastatic melanoma, both in the brain and in other parts of the body, for several reasons. For the brain, drugs sometimes don't have as much activity in the brain as compared to other parts of the body. So radiation is still being used to treat brain metastases, although we do know that nowadays with combination immunotherapy and possibly targeted therapy, they do have some activity in the brain. So sometimes we even omit radiation for patients with a small amount of brain metastases. So I'll probably just skip this part. I do want to show this again because as I see more and more patients, and they are getting more and more creative on what they do with the souvenir they get from the brain treatment. Because as I mentioned, we do very focused radiation to small area of the brain and the body. For the brain in particular, we want the head to be pretty much completely still during the treatment. And the way we do that is by making this mask that we do it in our department, which will be sort of bolted down into the treatment table, which was probably the worst part of their treatment for most patients, because the sound of bolting down their head to the treatment table is not a pleasant process. But I do find that patients do use these for great use. There are two ways to treat brain with radiation. One is the old and more comprehensive way to treat brain, which is whole brain radiation. We've done this for many, many years for patients with melanoma and other cancer in the brain. This is unfortunately still necessary in some situations where there is just too much cancer in the brain. This is usually done over 10 treatments over 2 weeks, and it does come with a lot of side effects, as you can imagine. Fortunately, more recently, we have developed more targeted or quote-unquote targeted ways to deliver radiation to the whole brain, and that is to spare parts of the brain that don't have cancer in them, and that can potentially spare patients some of these side effects, especially cognitive decline after radiation. This is just a comparison of different ways to deliver radiation to the entire brain. And on the left side, you have two beams coming from the left side and the right side of the brain, and everything in the middle is being treated to the full dose. On the right-hand side, if you can imagine the heat map, being the dose of radiation to the different areas of the brain, the red and yellow areas are receiving most of the radiation, and the blue or the gray areas right in the middle are what we call the hippocampus of the brain, and they are in charge of forming and maintaining memory in the brain. So there are studies that show that in patients receiving this type of radiation, omitting the or sparing the hippocampus, people have better cognitive function afterwards. Stereotactic radiosurgery, as I mentioned, initially was developed for the brain, but nowadays we can do it pretty much for all parts of the body. It is a very precise treatment that are delivered to over one or a few treatments to the brain or to other parts of the body. And for the brain, we use this special treatment machine called CyberKnife machine. But if you've met patients from other institutions, they might have been treated by something called gamma knife machine, or just the regular linear accelerator can do this type of treatment as well. And as I mentioned, I did add this slide because I do want to highlight the use of this focused radiation on other parts of the body. This is a patient that I've treated with, together with Dr. Cliccio, who had 2 areas of the body with metastasis from melanoma after several rounds of immunotherapy, and one in the left armpit and, right armpit. I got turned around myself. Unfortunately, the radiological images are always turned backwards, left and right is left. And one in the right armpit and one in the abdomen, and both of them are lit up on the PET scan and showing us they are indeed melanoma. So we treated both areas with this focused radiation or stereotactic radiosurgery, and both of them became more dormant, or as we say, probably most of the cancer cells are killed in those areas. And there is this thing called the abscopal effect, and that is what we are hoping to achieve with some of our newer treatment trials at UNC and at other places. The way we're trying to do that is by using radiosurgery or radiation as a way to stimulate the body's immune system to work better with the immunotherapy and to treat cancer that way. So this is an example of a patient that had received radiation not to the lungs but to the neck, and their cancer in the chest regressed after that treatment and immunotherapy. So Dr. Kletsch in our department is leading this trial that some of you might have heard of. It's called the MBTX R3 1100 trial for patients with isolated progression after immunotherapy of melanoma. And the way it works is by injecting this nanoparticle formed by, I guess, hafnium oxide nanoparticles. Don't ask me what they are. They are injected into the tumor directly, and afterwards they will receive focused radiation just like the patient I just showed you. And after that, they will receive immunotherapy, and the hope is that by the combination of the nanoparticle, the radiation, and the immunotherapy, the body will be able to resume the ability to fight cancer, not only in the area that's being treated, but also in other places as well. So other topics that we as a field are working on, not just for melanoma, but for other cancers as well, are flash radiation therapy, which can deliver radiation at very high dose rate or very quickly than, more quickly than regular radiation, or proton therapy, which some of you might have heard of, which unfortunately we don't have, or actually the general Chapel Hill or Durham area don't have, but hopefully will soon in the future. And what's called MR-guided linear accelerator, using MRI to show us the movement of cancers that are in the body in real time, is especially helpful to treat cancer in the lungs and in the abdomen. So take-home points: it takes a village to provide the best care for every patient with melanoma, and radiation oncologists are important part of the team, and focused radiation can treat tumors that cannot easily be removed in the brain or in the body, and new radiation technologies are hopefully becoming more mature to be able to be used in clinic for for melanoma and other cancers. So that will be it. Yes.
You made a comment that you could have, after stereotactic radiation or radiation,
Mhm.
you could have additional treatment.
Possible, yes.
Has that changed in recent years, particularly with the stereotactic radiation of the brain?
I think we're becoming more comfortable giving patients more focused radiation over 1, 2, or even more than that rounds of radiation than doing sort of more comprehensive radiation with whole brain radiation.
Hang on 1 second, I'm sorry, I can't hear you very well.
Oh, no worry.
You can
Sorry.
hear me because I speak loud, but
Yeah.
when you said you were more comfortable with it, is it
Mhm.
becoming more of a standard protocol
It
that
bec-
you can have
yes.
multiple treatments of stereotactic radiation surgery?
I would say so, although with the caveat, we don't often do it for the same spot. For example, if patients develop new spots in the brain after stereotactic radiosurgery, yes, we do repeatedly treat the brain with.
And that led into my next question. If it was the same spot that you had your first tumor, cells were discovered in that, I guess, gray matter that's left there.
Mhm.
And they radiated it. You could not go back and radiate that a second time.
We could still, with although the preferred approach would probably be surgically remove the area if possible for 2 reasons. 1, to remove most of the cancer, and 2, to confirm that it is cancer. Because after stereotactic radiosurgery, especially for the brain, there can be sort of competing processes. 1 is cancer cells can grow back, and 2 is the brain can be inflamed, and both of them unfortunately look about the same on the MRI. So usually we would like some sort of confirmation that it is cancer before we do the second round of radiation.
Makes sense. Thank you.
No problem. Great question.
Any other questions? Thank you, Dr. Chen.
No problem.
Well, I'm very excited to introduce Diane Bensley. She is the social worker for everybody, for many oncology patients, but specifically for our melanoma folks. And I teased her the other day that she should have a halo over her head. She's going to talk to you about something that is really pressing on many of our patients. It's probably one of the most serious side effects to cancer treatment, and that's called financial toxicity. And it's omnipresent and can, be more devastating than some of the medical side effects, physical side effects. Figure this out, I'm gonna let Trish do it. Okay. Let's see. Okay, now play. Just. So here's a pointer. Click orange back. Green if you want. Bring up the screen. Okay, I think I've got it.
All right, good afternoon, everybody. I'm Diane Bensley, like Paula said, and I'm here to talk to you today about financial toxicity due to cancer treatments. I am one of 4 oncology outpatient social workers in the cancer hospital. And financial toxicity really just simply refers to the financial hardships, the financial stress, financial burden that some of our cancer patients can experience while they're undergoing their treatments. As oncology social workers, we try to help reduce the financial toxicity any way that we possibly can. So some of the financial challenges that patients face during cancer treatments are the cost of treatment and out-of-pocket expenses. We know that cancer treatments can be very expensive. Even if you have good insurance, you still have co-pays and deductibles that can add up really quickly. Loss of income from reduced wages. Many people can't continue to work during their treatment, so their income is either reduced or it's just cut off completely. and transportation and lodging. How will patients that live far away, we get patients from all over the state, how will they get there if they don't have gas money, if they don't have a car, if they don't have someone to drive them? So we also know that financial toxicity can lead to reduced health outcomes. And this can happen very easily if patients, again, can't afford transportation to get to us. That can delay their diagnosis and it can delay their start of treatment. And patients, they just may not want expensive treatment if they don't have insurance. They may just say, I'm not going to do this, or I don't have money to pay my bills if I have to stop work. Other patients, and we've heard of this, have to make choices between expensive medications that they have to buy, or do I pay my household bills, or do I pay for food this month? And financial toxicity can also negatively affect patients' emotional and mental health. And again, this can cause delays in treatments. So I want to take a closer look at each of the categories that can cause financial stress. The first one is the cost of medical treatment. Obviously, this can be overwhelming, and like I said, it can be stressful for both the well-insured and the under or uninsured. We work with a lot of patients that don't have employer-based insurances. So do they have Medicare? Do they have Medicaid? Can we help them maybe determine if they qualify for Medicaid and help them to apply for this? We can't actually apply for them, but we can point them in the right direction and get them going. Maybe they would qualify for an ACA or an Obamacare marketplace plan. Again, we can kind of instruct them on how to go ahead and apply for these. We also have UNC financial assistance and pharmacy assistance. Maybe some of you have heard of this. This is for patients that don't have any insurance at all. And so these programs are based on their income, on their household income. So it depends on how many people are in their household, how many people are working. It does kind of depend on their assets. They're going to look at their bank statements and their taxes. But if we can get them the applications, and they can start applying for these. As social workers, we kind of get involved when patients maybe just are so overwhelmed, they just cannot get these applications completed, and maybe they can't find all their documents at home. There's a lot of documents, tax returns, bank statements, pay stubs. So we can kind of talk patients through how do you find these, bring them into me, I'll help you get them together. So they're great programs if folks don't have any insurance at all. In addition, UNC has a wonderful program for patients maybe whose job is ended and their employer offers them COBRA. I don't know if any of you have heard of COBRA insurance. So what it is basically you keep your employer-based insurance, but you would have to make those premium payments. You'd have to make your employer's portion and your portion, which can be really expensive. So UNC has a fabulous program where if a patient is in active treatment, meaning they're getting either radiation treatments or IV chemotherapy treatments, UNC, you can apply and UNC will make those COBRA payments for you. So it can be up to 18 months, which is what COBRA is. If you're in treatment for 18 months, UNC will make those payments for the premiums. What I like to say to patients, if you hear the word COBRA, don't panic, just call myself or one of my social work colleagues and we'll walk you through it, we'll get you the applications and we'll help you. So you don't have to remember all the details about it, but it is a great program. So the next category is loss of income from reduced wages. So some people who are employed may have employer-based disability benefits. They may have short-term or long-term disability. They can contact their human resource department and get signed up for those, and that'll bring in some income during treatments if they have to stop working. There's also Social Security disability. This is dependent on patient's diagnosis. And typically with melanoma, you'd have to be a stage 4 to qualify for Social Security disability. We as social workers cannot apply for you, but we can tell you how to do it. You can go online to ssa.gov, or you can call your local Social Security office in your area and get an appointment, and they can help you start the process of applying. The one discouraging thing about Social Security disability, if anybody's ever applied for it, is you have to wait 5 months after your date of, you're shaking your head, after your date of determination, which is typically the day you stopped working. So it can take a month or two to be approved, and then you have to wait that 5 months before your payments start. So that's a little discouraging. So we do have some cancer grant programs that can help with household bills while patients are going through treatments. We don't have a lot right now, but we have a couple things. The one that we use the most is the UNC Cancer Patient Assistance Fund. This is based on someone's household income. And what this fund can do is they can pay a utility bill of up to $250 once a year while someone's in active treatment. So again, it's not a lot, but it does help patients quite a bit. We also encourage patients to call 211. That used to be the United Way, so you can call 211 and tell them what county in North Carolina you live in, and they will tell you if there's any community foundations out there that can help with bills. Sometimes area churches have programs for utility bills. Sometimes there's like a Salvation Army or something in your county that can help. So we tell patients, call them once a month, see if there's anything out there. If patients have a disconnect utility bill, they can go to their local Department of Social Services, and if that county has money, they can pay that disconnect bill to get their power back on. So the next category, transportation, lodging. This is a really tough one for a lot of our patients. Transportation can be just an expensive barrier for treatment. We have, like I said, patients coming from all over the state, and some of them come quite often for some of their treatments. Medicaid, most of the Medicaid plans and some of the Medicare Advantage plans now have transportation benefits. As social workers, we can help you all access those transportation benefits. Our Cancer Patient Assistance Fund at UNC also has a gas card program. Again, this is based on income. And if you qualify and are getting IV chemotherapy or radiation therapy and you're coming at least once a month, we can get gas cards for folks, which can be really helpful. So lodging is also needed to accommodate those that maybe patients are having consecutive days of treatments or back-to-back treatments. Our Cancer Patient Assistance Fund can pay the cost. There's the SECU Family House. They can pay for the cost of that if it's back-to-back appointments and you qualify based on income. There's also a radiation lodging program where if you're getting daily radiation treatments, they have a program if you live 50 miles or more away that their program can help pay the cost of the lodging as well. So I think the most important thing to remember from all of this is if you are experiencing any financial stress or challenges, reach out to Paula, reach out to one of the providers and ask for a social work referral. We are always really happy to come and talk to patients and see what they might qualify for, what programs they're eligible for, because we want everybody to complete their treatments and to get the best care possible. And lastly, for the rest of us, how can we all help with financial toxicity? Paula and I were talking one day about the need for increased donations to these foundations, to the ones in the community and ours at UNC. And Paula had a great idea that how about at the next holiday or birthday, instead of a present, we asked somebody to make a donation for us to one of these foundations, because we decided, do we really need another ugly sweater or holiday tie? Any questions? I know I ran through that kind of fast.
I'm the question person. Does your program here at UNC help with patients that no longer is an active treatment in remission, or
That's a great,
a lot of the
yeah.
doctors say cured, but are still experiencing unintended consequences
Right.
that require medical treatment, and because of lots of immunotherapy, brain surgeries, and all of the things that were given to the patient, will we drug that just came out on the market. So I'd like to prescribe that to you, but you don't qualify through insurance, or you call the insurance company, or the doctor tries to get it approved, can't get it. The drug is new, it's in its orphan stage. The drug is new, the patient's suffering. The doctor comes back and says, your insurance turned us down to give you this drug because it's $4,100 an injection, you need one every 2 weeks.
Right.
It would help you a lot, but that's $8,000 a month.
Yeah.
Do you, in your program here at UNC, do you connect those patients? That's personally happened to me. I actually contacted the pharmaceutical company, and I'm going through
Right.
their financial assistance program, which that's jumping through a lot of hoops too.
Yeah.
The best thing for me is for he and I to get a divorce,
Yeah. I've heard that before.
to start all over again.
Right.
But, you know, who wants to do that? Because then he has to go live somewhere else, and we gotta pay those bills.
Right.
Or I have to go live somewhere else, and we have to pay those bills.
Right.
So, do we have an advocate here that works with the pharmaceutical companies is my
The MAP
question. That is the advocate with the pharmaceutical companies saying, you know, we have a patient, they can pay some, they're willing to pay some, but do we have a system?
Well, I think she's talking about the MAP program, right?
Well, because I spoke to Ms. Mazurko, she's talking about a medication that's treating a side effect from the cancer.
Oh, gotcha.
And that's where it gets tricky.
Yes.
Unintended consequences.
Gotcha.
She's not an active cancer treatment.
Right.
So it's very challenging.
It is very challenging because our programs, yeah, can only help patients that are in active treatment, unfortunately.
So what could we do collectively as a group, because everyone's probably gonna have some unintended consequences.
Yeah, I think exactly what you did. I mean, you can certainly call one of us social workers and we can, think about things.
Our F lady over there, get involved with her foundation, because I really think this is something that needs to go higher up.
Yeah.
To the government, because they make it impossible.
Yeah, no, I agree. Yeah.
So is that a reasonable thought or an unreasonable thought to move it on up?
Yeah, absolutely. I'm not sure the pathway of that, but yeah, I mean,
Is it worth researching?
I definitely think so, yes. Yes. Yep. Thank you. Any other questions?
Can you go on the UNC website to donate to the Cancer Patient Assistance Fund? How would one do that?
That's a great question. The lady I have the lady's name who runs it, her name's Michaela Klein. If you want to, I can give you one of my cards and you can send me an email and I will get back to you on how to do it. She sent me a whole list of how you do it, but I didn't bring it with me. But yeah, I can give you my card. Okay, thank you so much.
Oh, I lost the mouse. Okay, so next we have a representative from the SECU House. It's kind of on the heels of what we just went through of what they can offer to patients that need lodging. And I've personally never been in it. I've driven by it many times, but from many patients, it's a beautiful place to stay and only hear great reviews from it, so welcome.
Good afternoon and welcome to Chapel Hill. My name is Martha Aldridge and I work at Family House, and this is,
I am Claudette Witt. I'm the operations manager there.
yep,
I
and,
work closely with Diane.
all right, so Family House. What is Family House? Family House is a really friendly, loving place to stay. People that stay with us, it becomes like our family. We're a lot more than just a hotel. We have 75 rooms, and that's made up of both rooms and suites. and it costs $54 for a room and $72 for a suite to stay at Family House. Each room has private baths and roll-in showers. One of the best parts about Family House is the shuttle service comes directly to our front door and takes our guests and their loved ones to the hospital, to clinics around town, to Hillsborough, to Easttown, to Meadowmont, all around. The shuttle is available for the folks that are staying at Family House. We have laundry facilities that are complimentary. We have a stocked pantry and a full kitchen, and volunteers come in almost daily to prepare fresh homemade meals for our guests and loved ones. We have evening activities and programs throughout the day for our guests. We are very close to both shopping and walking. We're a little bit over a mile from the hospital. We're right across from the botanical gardens. So if you enjoy walking around in a beautiful place, we're right across the street. We are only available to UNC patients and their caregivers and their family members. Who stays at Family House? So it's often asked of us, how do you get to stay there? You need to live out, the patient needs to live from outside of a 50-mile radius of Chapel Hill. The patient is 18 years or older, and if they're younger, the patient, then they would stay next door at the Ronald McDonald House. All income levels are welcome to stay at Family House. We are not HIPAA'd in, so we don't have any idea, people's financial backgrounds that stay with us. One thing that is definitely needed is a referral from UNC, and that way we know that you are a current patient at the hospital to be able to stay with us. How to stay at Family House. As I mentioned, you need a referral from your care team at the hospital, a nurse, a doctor, a social worker, and there's information on the website about staying at Family House, and that link includes information on obtaining a referral and really what to expect when staying at Family House. Reasons for stay. So over half the guests that stay at Family House have some type of a cancer diagnosis. We have folks that come that are receiving transplants, bone marrow transplants, non-surgical cancer, non-cancer surgeries, cardiology, neurology, burn, really anything. You can come stay with us for any reason, as long as you fit those criteria that I went over. We have people that come from all over North Carolina. Since we've been open, we've had folks come from every single county in North Carolina and beyond, states all around the country and even around the world. But the majority of our patients are coming to us from the counties in North Carolina. A little bit about us last year. So I won't go over all these statistics, but we've had over 23,000 nights of stay at Family House in those 75 rooms. The furthest somebody came to stay with us was from over 7,000 miles away. And people tend to have a very positive experience when they stay at Family House. So as a patient or as a caregiver, that's probably the most important thing that I can tell you, is that our folks do really find a sense of community being with us at Family House, because you're staying around other people that are going through similar hard circumstances and times, and together you find company in that. We are a 501c3, an independent nonprofit. We have about a $2.6 million budget. About a third of that revenue comes from house revenue, and 2/3 comes from our development and fundraising efforts that we do all year round. We are very volunteer-centric, so we have over 1,700 volunteers that help keep our costs low. Even the people that stay help us clean up the kitchen or make meals. Whatever they feel like they want to do to help the community, they do. And it just becomes a really beautiful environment. We work very closely with the hospital and the hospital staff. They serve not only as referral sources, but sources of awareness. They make our patients and guests aware that we're there down the street. And then also they help us through sponsorships and fundraisers and special event volunteers, and then just volunteering themselves. We have groups from the hospital come often, almost weekly, to serve meals or to fold our laundry or whatever, but they're very involved. And then there's different volunteer opportunities, and I'll just highlight a few: laundry folding, kitchen help, front desk, music and arts. And then we have groups that come, different SECU, that's our namesake. Banks come from schools, churches, anybody that wants to volunteer, we love to have them help us out. Social media, if you're big on social media, that's important to us because, again, that's a way that we get our information out throughout the state about the work that we are doing for the folks around the state. And then if you have questions, so this is probably the most important page, there is a barcode that you can scan. And then if you have referral or admissions questions, Claudette is who you can ask. Volunteering, we have a volunteer director. Her name is Georgie, and she's wonderful. I do a lot with development and fundraising if you're interested. And then our executive director's name is Kelly Thompson, and her name is on there as well. And then I won't show it now, but this is just a guest story. His name is Darren, and he went through a bone marrow transplant, and he talks a little bit about the impact that Family House had on his cancer journey. So with that, I'll turn it over to Claudette for a second, really to answer any questions that you all have. She's the expert. She knows everything. So.
Yes, ma'am.
If a patient cannot afford the $54 a day, is there a sliding scale option?
Yes, there is a sliding scale. However, we sometimes, like Diane and them, have different funds that they have, and so we can balance the funds off each one. Like if they have something they can pay, we balance it off another fund.
Another question, if the family house is full, are there other options for patients?
Yes, ma'am. We do have surrounding hotels that we send them to at a discounted rate. They give us like a lower rate than they would give, like if you just called and asked to stay for the night. So they give us lower rates. We are running into that right now, but we're smoothing it out. Have anyone in here ever stayed with us? You've come for appointments or anything? You've stayed or, have a hand back there? All right. So if you are coming for any appointments and you need to stay overnight, you can get your caseworker or nurse or somebody to send a referral to us. We'll be more than happy to try to get you in. Yes, ma'am?
That's a great facility that you have. How long has it been there?
17, 16
We
and a half?
opened in 2008.
I was unaware of it.
Oh, really?
The other day, we made grilled cheese sandwiches and played bingo, and really appreciate you guys letting us come.
Thank you.
Thanks for doing that.
If you'd like to stop by another time that you're in town, I'd be more than happy to give you a tour.
I would love to do that.
Yes, ma'am.
Not today's rate.
That's fine. Any other day, you just come on by. It's not a Friday, but any other day.
I send a lot of patients to UNC, so it's good to know. I didn't know it. I knew the Ronald McDonald House was there, but I did not know about the family.
Well, I have a card that I can give you my card in case you need it. Okay.
Kelly's given us permission to park our travel trailer in the back parking lot this coming Friday. What hours does your shuttle run?
It starts at 8 a.m. Are you the people that are parking for 45 hours for your treatment and then going on vacation? Yes. She's on vacation. She made sure I knew about that. So yes, it starts at 8 a.m. and it runs all the way. It runs all day.
Okay, so we have our first appointment is before 8 a.m.
So
What are the options?
what I would do, because I need to give you a little parking pass to put in your window, I would suggest that you come in, I'll give you a number to call and set it up so they'll pick you up that time that morning. So if you're coming to stay with us and you have appointments before 8 a.m., the first shuttle, you can call them the night before and set up an early pickup.
Is there a limitation on the number of nights that you can stay?
As long as you have an appointment at UNC, a consecutive appointment at UNC, you're welcome to stay with us. No more questions?
All right. Well, please, don't hesitate to reach out to us with any questions. And as she said, we're open all the time, like the hospital. So pop by and come say hi. We'd love to show you around.
I am typically in-house between 9 o'clock and 3 o'clock. If you come by and just want a tour, just ask for Claudette. I'd be more than happy to come and give you one. Okay?
Thank you.
All right.
So I know many patients who have stayed there, and it's an incredible experience. Mel Baker is with our MAP program. That's the Medication Assistance Program, and I call them the wizards behind the curtain because they do yeoman's work in a very, very challenging situation. Many IV treatments for cancer fall under your insurance policy, but oral treatments do not. And the costs, the monthly copays, can be upward to tens of thousands of dollars. And she and her whole team wave their magic wand and help us. So thank you, Mel.
Thank you. Hi, everyone. Okay, I'm technology illiterate, so bear with me. So as Paula said, my name is Melissa Baker, and I am the technician specialist on UNC's Medication Assistance Program, or you'll hear me refer to it as a MAP, pharmacy benefit team. So anything run through your pharmacy insurance, we work with financial assistance options for you to give you med access for those medications. Okay, so you're probably wondering, well, what is the MAP team? Who are they? What do we do? All good questions, which hopefully by the end of the presentation, there will be some more clarification on that for you. We are a team of 26 people consisting of MAP specialists, nursing care coordinators, and a pharmacist manager. Our main goal is to make your pharmacy dispensed medications more accessible. So you're probably wondering, well, how do you do that? By assisting in 3 areas that typically pose the most problems for patients in medication access: prior authorizations, or you will hear me refer to them as PAs, copay assistance, our financial assistance that includes copay cards and grant funding, and manufacturer assistance programs, also better known as free drug programs. So prior authorizations, how does this process work? Your provider prescribes a medication for you and sends a prescription to the specialty pharmacy. The pharmacy then completes what we call a benefits investigation by submitting a test claim to your insurance plan. The insurance determines if the claim will go through or if they need additional information from your provider. If more information is needed, the MAP team is then notified. We submit the PA along with the additional clinical information to the plan and follow up as needed until a decision is reached. If the PA is approved, the pharmacy will rerun that test claim that I mentioned and proceed with next steps from there. If the PA is denied, once advised by the clinic, our nursing care coordinators will appeal that decision. There are 2 main ways that we receive PA requests. They can come directly from our specialty pharmacy in-house at UNC, or as the patient, you can inform your provider or your clinic team that your external pharmacy cannot fill the medication because a prior authorization is required. As I mentioned, if a prior authorization is denied and the clinic requests it, the decision made by your insurance plan can be appealed. This process is handled solely by our nursing care coordinators. They draft the appeal letters, send to your providers for any edits that may be needed, and submit to your plan for review. Once submitted, they will follow up with your insurance plan until a decision is made. In addition to them working through appeals, our nurses serve as an excellent clinical resource for not only our clinic partners, but for our MAP specialists as well. One of the biggest areas that poses an issue for patients in medication access is the cost of their medications once the claim has been approved by their insurance. Financial assistance can be a very broad topic, but it is a big portion of the MAP specialist's role. There are 3 main categories of financial assistance: copay cards, grants, and manufacturer assistance or free drug programs. Each category has specific qualifications, and the MAP specialists are trained to determine which category each patient fits into. They will also find any and all assistance available for that patient. Copay cards are for our commercially insured patients, so patients that have Blue Cross Blue Shield, Caremark, Aetna, those types of plans, and they are the easiest to obtain. Grants are funded by outside foundations and are for both our commercially insured patients and government insured patients. Each foundation has different eligibility requirements and can sometimes be a bit more difficult to obtain than the copay cards. Manufacturer assistance, better known as free drug programs, are for our uninsured, underinsured, or our Medicare patients. These programs have the most eligibility requirements. They tend to be the most difficult to navigate and take the longest to obtain. Because manufacturer because manufacturer assistance takes the most time to obtain, it is the financial assistance category that the MAP team spends the most time on. So you're probably wondering, what is manufacturer assistance and what all is involved? Programs that are sponsored by the manufacturer, such as Pfizer, Bayer, Merck, Genentech, etc., that provide free product to eligible patients. Now, for our side of things, they do not cover other medical costs or supplies, only the prescription medication. As previously mentioned, these programs are for our uninsured, our underinsured, or our Medicare patients. Each program has specific eligibility requirements, but it often includes household income and a residency within the U.S. So how does the MAP team help? Where do we come in? We act as the point of contact for both the patient and the clinic. We will communicate with the patient to obtain the required documentation. We will also work with the provider to obtain signatures and clinical records. Once we have everything we need from both parties, we will submit the application and track its progress. Should any issues arise, we will work with the manufacturer directly to resolve them. Once we receive a determination from the program, we will inform the patient and the provider and clinic team. For MAP specialists to help with manufacturer assistance enrollment, we need consent to do so. So we need your permission. To obtain this, the MAP specialist will send a signature waiver to the patient for completion. This waiver allows the MAP specialist to complete the application and submit it and any needed documentation to the program on the patient's behalf. So we kind of act as a middleman. In addition to the patient's signature, the MAP specialist will often need to know household size and income of the patient. So what happens once a determination has been reached by the manufacturer program? If the application is approved for assistance, the patient and the clinic will be notified of the approval. The prescription will be delivered directly to the patient's home at no cost from the manufacturer program's contracted pharmacy, and patients are able to coordinate future shipments directly with the program. If re-enrollment is needed, the MAP team will support that process in the future as well. If the application is denied, however, the MAP team will notify the clinic so that they can start planning next steps for the patient. So in a nutshell, that is the Medication Assistance Program Pharmacy Benefit, or MAP team. I hope that has provided some background clarification for you all. I appreciate your time. Thank you so much. Yes, ma'am.
I have a question. You have a patient that has no insurance, doesn't file taxes, does not have a bank account, and you go, because this happens sometimes, what do? What do you send to the manufacturer?
So no bank account, no insurance, no file taxes. So if they don't file taxes, most manufacturer programs will allow like a no income letter. Basically, the patient is attesting that they don't file the taxes, they don't have any active income coming into the home, and we can submit that on the patient's behalf to the manufacturer program. And most of the time, they accept that that letter. So yes.
What are you finding that your average lead time is now from the time that you get the patient's application to the time that it's a decision's made by the manufacturer?
As far as when we submit the manufacturer application?
Yes, ma'am.
I haven't been in that exodus. Maybe 2 to 3 weeks once it's submitted. There's a lot of previous work that goes into gathering all the documentation and all that as well. So I wouldn't say our exact turnaround time is 2 to 3 weeks, but once it's submitted, outside of renewal season, it's usually 2 to 3 weeks turnaround time.
Has that improved over the last few years, or?
We've definitely gotten faster, but because there's so many factors that go into it, it's hard to pinpoint exactly how long. But our hope is to get the medication for as cheap or free as possible, as quick as possible, so that therapy can be initiated or continued. Yep. Yes?
I was wondering, is this just for oncology meds?
No, so, no, our team helps clinics across the state, any UNC-based clinics across the state. We do have specific MAP specialists in the melanoma clinic, but depending on, we have 26, so we can't cover the entire state, but we do have any UNC-based provider that sends a prescription. We are able to help with any med access barrier for them. So no, it's not just oncology-based. Any other questions? No? Okay. Thank you, guys.
Miraculously, we are almost on time, which is unheard of with UNC, period. So take a break and come back at 2:30. So there should be some snacks and beverages out there, and then we'll see you in about 10 to 15 minutes.
We are back. All right, so we are coming a little bit full circle from where we started with Dr. Calicia's talk, where she talked about clinical trials, and we now have Blair Adams from the Clinical Trials Office, who's going to give us a little bit more information of exactly what a clinical trial is, how one can benefit from the clinical trial themselves, but also for our society in general. So really excited to have you here to give us this talk. Thank you.
Well, thank you so much for having me here today. My name is Blair Adams. I'm the Assistant Director of Clinical Operations for the Clinical Trials Office here at Lineberger. So typically, we want to talk first about what clinical trials are. They are research studies that involve human volunteers. These studies can be observational or interventional in nature. So what that means is patients can be receiving therapy for their cancer diagnosis on these trials. They can be part of a cancer registry. They can be part of screening initiatives. They can be answering questionnaires or be a part of quality and life improvement studies, so on and so forth. So all of this research is really important into improving cancer outcomes. I know earlier you heard a lot about different clinical trials that have improved care thus far in the melanoma spectrum. I do want to highlight the first known clinical trial in the modern era. So Dr. Lind was a physician on a British naval ship in 1747 who started observing scurvy symptoms in sailors that had been at sea for quite some time. And so what he did in that observation was to divide these sailors into multiple groups. He administered different interventions, some of which were giving them cider, some were having them ingest seawater, but the most beneficial outcome was observed in those patients or sailors that were intaking lemons and oranges and other citrus fruits. And so what that showed him was that these patients were resolving their scurvy symptoms through this ingestion, and that led to the knowledge of how to treat and prevent scurvy. So while that is an easy example, it really highlights the importance of what clinical trials can show us to improve care. So like I said with Dr. Lind's example, the importance of clinical trials is to help provide better ways to prevent, diagnose, treat, or manage cancer and its associated symptoms. This improved knowledge can really help us know more about cancer and its associated care. And we found that outcomes for our patients that are diagnosed with cancer have improved through the improvements with clinical trials, and we are seeing patients that are living longer as the result of previous trials. Many of the treatments that are approved today in the standard of care setting were once tested in a clinical trial, and the FDA does require that new drugs are first tested in clinical trials prior to seeking approval. So why participate in a clinical trial? Clinical trials enable patients to gain access to new therapies before they're widely available to the general public. This is based on the most up-to-date research at the time. And so what this enables patients to do is receive that early care. It does take quite some time, sometimes decades, from discovery of a new drug to the approval through the FDA. So this is a really great time to capitalize on that treatment if it's available through a clinical trial. Additionally, when patients are enrolled on clinical trials, they do receive very close medical care from a team of experts. This includes their treating physician, the research team, nurses, pharmacists, et cetera. And so there's a lot of careful and frequent monitoring that patients may not receive in standard of care just because of the monitoring that's required by clinical trials. Additionally, this is a great way to help others by contributing to the future of medical research to add to the overall knowledge and improve care outcomes. So how do you find a clinical trial? So the first and best way to do this is to ask your doctor. If you are receiving your care for your cancer, your loved one or your family or friend is, you can simply ask your doctor. They're likely aware of what is currently available, either here at UNC or across the state. Another great way to do this is to search online at clinicaltrials.gov. You're able to search by cancer diagnosis, what stage you may be, and things like that, see what's open at our center, but across the country. Additionally, we've put a lot of effort into, over the last few years, advertising what is available here at Lineberger. And so you are able to navigate to our Lineberger website. This Find a Clinical Trial snippet here will show you what button you would need to click on. You're able to search through Research for Me what is available currently and is open at our institution. You can also email our cancer clinical trials email inbox and just state what's going on, what you need, and we can help with our research teams further guide you to what trials we have available. Additionally, we have these Research for Me QR codes. They are a great way to directly link to the Research for Me website. They are widely available in our clinic patient rooms at the cancer hospital. They are also on everybody's after visit summary when they are seeking care at UNC Health. So no matter if you're getting your cancer care or you're going to your primary care provider, I know this specifically because I see it on my son's AVSs and my own when we're seeking our general care. So it's a great opportunity to take a look at that, whether you get a printed version or you are accessing this through your MyChart. So what happens after you are a patient and you've been approached for a clinical trial opportunity? First off, your treating physician and the research team may talk to you about what this trial means in the context of your general care, weighing the standard of care options, if there are any, versus the clinical trial. This is a great opportunity to learn from this team of experts early what the trial involves, ask about side effects, any questions you may have, understand your responsibility as a patient as well, and ultimately make a decision. If you do decide to join the clinical trial, you would give your informed consent at that initial period, and then screening activities would begin to assess your individual eligibility for the trial. If after all of that, the team is able to review the eligibility criteria and determine if you are eligible for the trial, you would then be enrolled to the trial and the treatment would begin. So during the trial, there are regular check-ins specified by that individual clinical study to check in, test your health, see how things are going, monitor you for how the treatment is working, but also keep an eye on side effects and things that may be impacting your continued ability to receive that treatment. These things can look like labs, biopsies, specific biomarkers, and samples taken for the research team to analyze later, visits with your provider, with the research team, scans, biopsies, questionnaires, and things like that. And then after your treatment ends, whether you complete the treatment as it's intended by the clinical trial, maybe your disease has not been responding to the therapy and you need to seek other treatment options, you would come off treatment, but there are routine follow-up periods in most clinical trials that patients are able to continue to be followed by the research team and their provider after the treatment ends. After the trial, these results can really help doctors and researchers evaluate the safety and effectiveness of these interventions, and the goal overall is to improve care for future patients. And so, like I said, the goal is to submit successful interventions to the FDA for approval, but we can't do any of this unless patients are enrolled to these clinical trials and we're able to analyze the outcomes. Next, I'd like to talk about safety and ethics with regards to clinical trials. So what are your rights if you're participating on a clinical trial? These clinical trials are voluntary, and this cannot be stressed enough. If you are enrolled in a clinical trial, you can change your mind at any time. It's really important that you talk to your physician about that decision so they can guide next steps and see what your care may look like. But that is really important that you know throughout the entire course of the study that is a voluntary nature. And I will also state that informed consent is not a one-time process when you first sign up for the trial. It's an ongoing process. And so what happens is oftentimes there are new risk and notifications or benefits or things that change about the trial over the course of the time, and the research team is obligated to share that with participants as soon as possible so that patients can make an informed decision about their continued participation on the clinical trial. In terms of safety measures, trials do follow strict guidelines to keep participants safe. There are ethics committees that do review each study to protect the patients enrolled in the trial. This happens both at the initiation of the trial at the local site, but also at routine annual review. There's also checkpoints built into trials that the sponsors will evaluate the data that's been generated thus far to continue, see if the trial is worth continuing, evaluate the safety, and then continue proceeding if that is the direction they choose to go in. Oftentimes also there is routine study monitoring at the site level. Sponsors will send in their representatives to monitor at routine intervals to ensure that the site is doing everything according to the outlined protocol, review the data that's been entered, issue queries, make sure everything looks clean for submission. Patient information is kept confidential, and that's an important aspect of participating in clinical trials. Sometimes people think that they'll be identified in any type of publication that goes out after the trial ends, and that is not the case. Each patient is protected by a random number that is assigned to them, so that when data is pushed forward to the sponsors and other agencies, that they are not singly identified. Additionally, each new treatment does undergo several phases in its investigation to ensure that it is appropriate for submission to the FDA. So typically, these look like phase 1 through 3 trials. You may have heard those terms before. Phase 1 trials are really aimed at investigating the drug in a smaller subset of the population, making sure that it's safe, what's the most appropriate route of administration, and what is the best way to give, as well as determining what the initial dose is going to be set at. So typically, this can enroll between 15 to 50 patients. Like I said, it's a much smaller group. Depending on the success of that agent in that particular trial, it can go on to the phase 2 portion. So this is really looking at, is this effective in treating the cancer diagnosis that it's intended? What are the side effects? This is a larger group, although it is not nearly as large as the phase 3 portion of the trial. So the phase 3 portions can enroll hundreds of subjects. It compares how their new treatment oftentimes works in comparison with the standard of care therapy that's currently on the market. And like I said, enrolls a much larger group. All right, so common questions, things that we hear a lot at our site. Who can participate in clinical trials? So not all clinical trials can enroll every patient that has that specific diagnosis. They're not created for everyone, but they are created to answer an important question. And so the eligibility criteria is unique to each individual study. And so it's really important that patients understand this when they are being approached for trials, that even if they are screened for trials, they may not be eligible to enroll. Additionally, patients from all backgrounds are encouraged and needed to participate on clinical trials to create better treatment and outcomes for the future population. So what we don't want is only certain groups of individuals enrolling on these trials, and that specific indication and approval is only relevant to a certain group of people. So for example, all ages, all races, all sexes are really important to enroll on clinical trials so that we have a very wide scope of what these treatments can be applied to in the future. Will I get the treatment? So some patients do get the new treatment, while others may receive the current standard of care therapy on the trial. Typically, like I said, this is in those phase 3 portions of trials. Randomization occurs, so what that means is a computer typically will randomly assign, like a flip of a coin, a patient to either the intervention or the standard of care treatment. But what I will note is in those specific situations, it is not uncommon for sponsors to allow, if a patient's disease has progressed on the standard of care treatment, sometimes patients are able to roll over and receive that interventional treatment as well. Another big question we get are, am I going to get a placebo? Placebos are rare in cancer clinical trials, and if given, they're often paired with a standard of treatment. So you will receive treatment, it might just look different than receiving the specific intervention of the trial. And what are the risks? Side effects are possible with any treatment. There is a potential risk that could be occurred to the patient. Those side effects are oftentimes outlined in that informed consent conversation before a patient joins the trial. There's also the risk that the new treatment may or may not work. We as clinical trial teams are very clear and upfront about that with our participants. During the informed consent process, the goal of the research is to find out if it does or doesn't. And lastly, will it cost me anything? This is another big question and concern for patients. So there are research costs that are associated specifically with the trial. Sometimes that means the interventional agent itself. Sometimes it's specific tests that the sponsor has indicated are needed to research the particular drug. And oftentimes those charges will go to the sponsor. In terms of insurance and patient coverage, typically things that are part of your normal routine cancer oncology care would go to your insurance. And so that's all decided at the level before the trial even starts at the site. And then some trials, this is really great, do offer reimbursement for travel and lodging. And so when your consent conversation is happening, that is something that your study coordinator and team would talk to you about, so you could determine the best ways to go about doing that. All right, so after the trial completely ends, I'm not talking just for the patient, but overall, what happens? So the data will be analyzed. The researchers will review the data upon study completion to determine if it met their primary and secondary aims. The research results will be published following this review on websites like clinicaltrials.gov, in medical journals, and other sources online. And then at the site level, the research team does have the intention to share those results with individual participants, and that is definitely something that we really strive to do. Whether the results were positive or not, that's something that's important to share back with that person that gave their time to the research. And then, like I've said before, the goal is to submit for FDA review and approval. So if the trial has been successful and the sponsor elects to submit for a new drug application, they will submit these results to the FDA, and the goal is to have more and better treatment options for patients down the road. So in closing, patients are such an important aspect of the clinical trials work we do here at Lineberger and also across the world. We could not do our research without all of your involvement, so I wanted to thank you for that. We've heard some really good resources earlier today, the Medication Assistance Program, the SECU House, what our wonderful social workers can do. I also wanted to highlight some other additional resources as well. So there's a great comprehensive cancer support program here at Lineberger for patients and families. It's located in the cancer hospital. We have clinical trial patient navigators through the CREATE initiative. Patient Financial Services is a wonderful resource. And then, like I said earlier, we have our cancer clinical trials email box that anyone can send an email to, and somebody will get back to you shortly. I wanted to thank everyone for being here today. We're all here for a reason, and it's all specific to you. So you may be here to support your loved ones, hear more about the cancer that's impacting you and what advancements have been made, here to support others on their cancer journey, find better ways to treat, predict, and care for patients with cancer. I wanted to share personally that a few years ago, my father passed away from metastatic pancreatic cancer. And while that was a very sad moment for myself and my family, it does drive the work that I continue to do here at Lineberger, so that eventually, hopefully down the road, families and patients don't have to go through what my family personally experienced. So thank you so much for your time. I appreciate you listening to my presentation. Okay.
Stage 4 at the time in 08, they said. I am still here. However, when I got a call 6 years later in 18, they said, I did get the real thing. I'm the only one left that got the real thing. I don't know about the others, but I never saw any kind of report of what happened.
Okay.
Except I know I'm a real survivor, and I'm glad.
Yeah, well, we're so thankful for your participation on the trial, and I'm so sorry you haven't heard. Yeah.
I think I'm a walking miracle, but I don't know why.
Well, I'd be happy to give you my email address and personally connect.
I know who did the trial.
Uh-huh.
Who sponsored the trial.
Okay.
Trial with their drugs. However, after 6 years.
Yeah.
Something else happened. I couldn't be on their drugs anymore, but
Gotcha.
I'm on somebody else's for the last 6 more years.
All right, well, I'd be happy to give you my email address so we can connect. Yeah.
If anybody wants a recommendation, if they can get in it, do a clinical trial.
Thank
because
you.
it just might save your life, because it saves mine.
Yes.
I have a question. Can you define, just for everyone, what a sponsor is and what
Sure.
a sponsor responsibility is?
Sure.
And how they collaborate with actually
Yeah.
your primary oncologist, how that works? Because I know a lot of oncologists say, well, there is this clinical trial. I'm really not involved in it, don't know a lot about it.
Yeah.
How does that collaboration take place?
Sure, that's a great question. So when I talk about sponsors for clinical trials, we're thinking of our pharmaceutical companies. Lineberger itself also is a sponsor of clinical trials, so we have our own investigator-initiated trials where we are both the sponsor and the investigator. But when we're thinking typically about sponsors, it's your pharmaceutical companies, so like Merck, Genentech, places like that. And so typically they will develop a protocol concept. They have research teams that are dedicated specifically to liaisoning with clinical trial sites to assess if that is a trial that they would be interested in opening, and there's a lot that goes into it. So are there competing trials? Does the site have the resources to conduct that trial and things like that? So there's a lot of early conversations with the investigators at the site, with the clinical trial staff to see if that's a trial that they would be willing to support and bring on. And so there's a lot of those conversations in the background. Sometimes when you say a provider doesn't know about a trial, it may be because we haven't opened it for a variety of resources, whether it's competing studies, that we don't have that population here at UNC and things like that. But that's typically what that process will look like. And then if a trial is accepted, we would start activating at the site, and that can take some time because there's a lot of budgetary things that we need to look at, and there's a lot of work that goes into implementing a clinical trial. Yeah, I hope, did that answer your question?
It did, yes.
Okay. Any other questions?
Just one thing to add, if you visit melanoma.org, we have a clinical trial finder where you can put in, where you live, specifically related to your disease, and it'll help you find a clinical trial that matches your criteria, because there are exclusion criteria. So even if you see a clinical trial, it might not be applicable to you based on some of that exclusion criteria. We also have a service called Ask a Nurse. We have a full-time oncology nurse on staff that you can email at any time, askanurse@melanoma.org, and she will also help point you in the right direction if you're looking for a clinical trial.
I just know my doctors and my surgeon, my physician, I think they all work to get me into the trial. I'm grateful.
Well, we're grateful for you participating.
It worked. And the nurses.
All right. Well, thank you so much.
Would I do the arrow here? Yeah, that's the okay. Yep, that's perfect.
Yeah.
Okay,
Forward, back, and then.
this one's, okay. All righty. So many times you may have heard us say, we're going to talk about your case at Tumor Board. Tumor Board is a terrible name for our multidisciplinary conference, much nicer name, that we have twice a month, where the melanoma team, and that's everybody from medical oncology, surgical oncology, radiation, radiology, clinical trials, pharmacy, dermatopathology, we all come together on Zoom and we talk about new patients, challenging patients, anybody that is brought to the agenda. So we thought we would do a case study here based on a real patient situation. I've invited 3 of our excellent providers to come help out. So if excellent providers could come up, Dr. Hanks, Dr. Alrohill, and Dr. Doherty. Usually there are sometimes 12, 15, 20 people on the conference call, but today we have 3. All right. And if each of you can introduce yourself and tell us what you do here at UNC. Dr. Hanks?
I guess I'll start. My name is Brent Hanks. I'm a medical oncologist, physician scientist.
My name is Kristen Doherty. I'm a surgical oncology fellow.
I'm Rami Rohil. I'm a dermatopathologist here at UNC.
Okay. So again, this is based on a true story. The identity has been switched around a little bit. So GM is a 51-year-old male who lives in the Triangle with his partner and is a software engineer. He's had this mole on the right side of his neck for most of his life. And then in the fall of 2023, he nicked it while shaving, and it started to ooze and grow. So a full year later, in 2024, he presented to a UNC head and neck surgeon, and that's just the way hear me, I'm so sorry. Is that better? Okay, sorry about that. Trying to be Phil Donahue for anybody who knows Phil Donahue, but I'm dating myself. So the referral came to a UNC head and neck surgeon after a biopsy was done by his local dermatologist. And for most of our new patients, those slides that are done by the local dermatologist come to us at UNC, and Dr. Alrohill and Dr. Medema review them as well for another pair of eyes. Okay, the pathology. So as Dr. Ferris went over, the Breslow depth was at least 8.5 millimeters. It was ulcerated. It had a very high mitotic rate of 21. It was a T4B, so pretty deep, and that B came from its being ulcerated. And it had this BRAF mutation, which Dr. Colicchio mentioned is a mutation on the melanoma that he did not inherit, nor would he pass on to any children. But it can be a factor in future treatments. We will look at the slides in a moment, but traditionally, Dr. Hanks, would you then send this slide off, this specimen off for genomic testing with a company like Tempus or Foundation One?
So being new at UNC, I can tell you that my practice before was that I would not necessarily send it off.
Okay.
And that we would actually get targeted genetic studies for BRAF mutations, as well as some of the more common mutations. But if you order one of these testing options, that's certainly one way to go. You're just going to get a much broader array of genetic targets.
Okay. All righty. Dr. Alrohill, can you show us the slides?
Sure.
And Trish, I don't know if you're going to, because we're going to have to exit this and bring up yours.
Nope. It's neither.
Yeah, we did send them in. You did not bring a flash?
No.
Okay. All righty. Bear with us for a moment. Technology is great till it doesn't work. So. We did send them to.
Is this you, melanoma? Let's try this. Patient day. Let's close this. Let's try reopening those.
So it should be titled 407 case pathology images.
What time is it supposed to be? What time is it now? It's 3:03. This is 1500. Is this not it? No.
So it should look like this, and the title should be this.
Do you have a way to send that?
Yeah.
Okay, here, let me. Scan that and then send it to that. Or drop it into there.
Drop it?
Yeah, into a Dropbox, and then we'll just pick it up from here. And then just take that file and drop it in.
Oh gosh, is that gonna work?
You just send it to Beckett.
You could do that too.
What's the email?
Sorry, it's conference tech. Here, sometimes it takes longer though.
download it and also upload it. Yeah, I should have checked if it was on. But I assumed that it was.
I assumed as well, so.
Did it both ways.
I apologize. We thought we had everything set up, but clearly, yeah, we were doing so well.
Well, the one thing I can, like, it's rare for a dermatopathologist to show his face to patients, and for patients to even know what a dermatopathologist do. So just to introduce myself, I'm Rami, I'm a dermatopathologist here at UNC. What we mainly do, our role is, if anyone takes a biopsy from you, or an excision, or a sample, or a needle core biopsy, that tissue, we look at it under the microscope in order for us to define what kind of tumors is happening in the skin. My specialty is dermatopathology, so it's skin specifically skin. So we assess the tumor, what type of cell it is. We assess the prognosis of the disease. So when we say the depth of the melanoma, we measure it microscopically. It's not eyeballing, it's not a ruler. It's more of a microscopic measurement to tell what is the depth of the melanoma, and that's how we can decide is it T1, T2, T3, T4. Ulcers, sometimes like the ulcer is very obvious clinically, but they're microscopic ulcers that we only see under the microscope. So that's another thing that we assess microscopically to tell you, the patient, what is the pathologic stage of your disease. Other things we assess is lymph node status when we get lymph nodes, so we detect the metastasis if it's clinically occult where it's not felt, but it's micromillimeters, and we measure it and we're able to see it under the microscope. So that's mainly our role in what we do in dermatopathology, to assess to allow for your surgical oncologist and your oncologist to later on decide what type of treatment and therapy for you to undergo. Great. So this is the shave biopsy. That's how it looks on low power. So when the tissue is taken, we look at it at the bench, and after that the tissue is processed so we can put it on a slide. And when it's placed on a slide, it's usually looking pink like that. That's how it looks like. And believe it or not, that's what we read. These are mainly how they look like to us. So we can see a big nodular lesion, like we see this almost mushroom-like growth on top over here. And here the background shows you the normal skin being present. So this is the measurement of how we measure the thickness of this tumor. So this one is, it's a very thick lesion. So the highest thickness is 4 millimeter. Most melanomas that I diagnose in my practice that come mainly from dermatology clinics are usually less than 1 millimeter. So higher than 4 is rare, but it does happen. And usually the thicker it is, the worse it is. For you to visualize what 1 millimeter is, 1 millimeter is basically a dime thickness. So the thickness of a dime is 1 millimeter basically. So this is like 8 dimes stacked on top of each, 8.5 dimes stacked on top of each other. So it has a lot of thickness to it. On closer inspection, when we look at it, we see this is on this side, this is the skin surface, which is called the epidermis. So this is what our skin, what you're seeing on your skin surface. This is the epidermis. This is what it looks like microscopically. And on this side, we see it's absent. So this is a definition of ulceration. So we have ulceration that upstages the melanoma. And lastly, this is the tumor on closer inspection. So we can see this nested-like growth. There's like subtle nests and sheets of cells of really atypical cells with mitotic figures. And on close-up images, we see like in the center, what we mean by mitosis is a cell that's undergoing division. Our normal cells, for the most part, like a regular nevus, is silent. It doesn't undergo mitosis, it doesn't regenerate. But melanoma, it's replicating. So that's why we see that even in our eyes microscopically of a cell undergoing division, cell division. So these are parameters that we record. So that's how we were able to reach thickness of 8.5 with ulceration, with multiple mitotic figures. And that's how it translates into PT4B, the pathologic stage T4B melanoma in this case. That's it. Thank you.
Trish, SOS. Yeah, you're my tech guru.
Oh, okay.
Thank you.
See, I might have to get him because I'm not.
To get back to
All right,
mine.
Paula's gonna talk.
I'm going to talk. We're trying to get back to my slides. That's why I didn't go into STEM. Okay. It did work beautifully. It's been jinxed today, so.
That's pretty much standard meeting protocol. It worked last night.
Yep,
So I have a naive question.
of course.
Had the patient not reached the mole, would it have not, I mean, was
Yeah.
it melanoma?
What time was it for?
We're discussing your case. Yeah, I mean, that's a really great question. You know, it probably would have declared itself soon thereafter. It was probably a good accident. And we do hear that in other wacky ways that things have been discovered. Yep.
I may not be that guy, but I did shave off that mole, so.
Okay. Thank you so much, sir. Okay. So then the ear, nose, and throat provider ordered a CT of the chest, abdomen, pelvis, and neck, looking for metastases. Can you hear me? Yeah. Looking for metastases. The chest CT was normal. The abdominal CT was concerning. It had several, when they say lytic foci, so many of the bones had some lesions in them that looked concerning. And if you've ever read a radiology report, they don't say anything definitive. They can say things like concerning for, worrisome for, suspicious for, because they can't diagnose unless there's a biopsy. And then this gentleman happened to have a large kidney stone in his left kidney, and they also said suspicious for this fancy word that is inflammation of the kidney. And this is a picture of the CT scan in the pelvis. And the provider, the oncologist that took care of this patient, said it was very hard even to appreciate those lesions on a CT scan. So the ENT provider said, we need some help here, and referred this gentleman to see one of our melanoma medical oncologists. And we saw him in November of 24. And we ordered a PET scan and a brain MRI just to get a better picture of the whole body, including the brain. The PET scan is not great for looking inside the brain, so that brain MRI is kind of the gold standard for looking for metastases in the brain. And then on clinical exam, you can see that there were some satellite nodules at the primary site. Thankfully, the brain MRI was normal. His creatinine, which reflects kidney function, was slightly elevated. And there was a finding on the scan of a thyroid nodule, which we did get a fine needle aspirate of it later, and it was benign, it was fine. The PET scan, as I said, showed this right thyroid nodule. And then they said, you know what, we looked at these bony lesions and we can see them, but they're not really lighting up and they're probably too small to appreciate on the PET anyway. So we weren't convinced that that was a bone metastasis that we were looking at there. So melanoma staging can be pretty complicated. They look at tumor depth, lymph node involvement, and metastases. And under that N for lymph node involvement is kind of a subtype of what we call satellites. So you may recall that the clinician saw satellites at the primary site. So the final staging was a T4B, reflecting that worrisome depth with ulceration. These satellites, which made it an N1C, and then no defined proven metastases. So it came out to be a 3C. So the question is, what do we do next? Do we lead with surgery? And Dr. Dougherty, do you want to comment now on what we should do as far as surgery?
So typically in this scenario with the satellite lesions, we would not lead with surgery because we would try to get rid of those and sort of quote unquote downstage the cancer with therapy up front, systemic therapy.
Okay. Dr. Chen from radiation could not stay for this tumor board, but I did ask him to chime in, and he said radiation would not be his upfront modality here. So then we've got a gentleman with a BRAF mutation for which we have pills, but we also know that immunotherapy can give you a more durable response. So, dear Dr. Medical Oncologist, what would you recommend next?
I think really standard of care in these circumstances is start out with some form of immunotherapy up front. And we know now, probably over the last few years, probably the biggest advance that we've made from a systemic therapy perspective is our understanding that upfront, or otherwise known as neoadjuvant immunotherapy prior to surgery, can really improve outcomes in the long term. So we really, whenever possible, we try to start these patients out with some form of immunotherapy before surgery.
Okay, and that word, and Dr. Cleacha mentioned it, of treatment before surgery is called neoadjuvant treatment. But then we had another quandary. Do we lead with SWOG 1801, which was pembrolizumab or Keytruda for 3 cycles prior to surgery, versus the NADINA protocol, which is immunotherapy of ipilimumab and nivolumab? What do we do next? I mean, toss up. Dr. Hanks?
Well, I think, truthfully, we don't really have any head-to-head comparison between those two strategies. So there's not necessarily a right or wrong way here. I think when you're looking at combination immunotherapy, which would be the NADINA protocol, you're looking at 2 cycles of ipi-nivo, ipilimumab, nivolumab immunotherapy. While the objective response rate, or the ability to shrink the tumor, is quite high, you're looking at almost 60%, really 56, 57% response rates. However, the toxicity and the side effects are going to also be much more significant. So we see anywhere between 35 to 40% of patients will develop a higher grade toxicity on that protocol. So that is something to consider. And then we compare that with the SWOG 1801 protocol, which is an anti-PD-1 antibody, in this case pembrolizumab or Keytruda, which is another form of immunotherapy, and that's given 3 doses before surgery. The response rates are modestly lower, but the toxicities are also quite a bit lower. You're looking at 7% grade 3, 4 higher toxicity rates relative to over 30%.
Yeah.
So I think there's really no clear answer for a lot of these cases.
Now, you may recall that he had some kidney concerns, some inflammation in the kidney. Would that weigh into your decision?
Yeah, absolutely. I think that would be a very reasonable thing to be concerned about. I think fortunately, the incidence of interstitial nephritis or kidney toxicity on these regimens is actually quite low. You're looking at higher grade toxicities at less than 5% of patients that are treated with these therapies. When you combine it with Yervoy or ipilimumab, it is going to go up a little bit. So I think that's reasonable to consider. And given the unusual read from the radiologist in terms of his kidneys, that would be something to be concerned about.
Okay. And I know for ipi-nivo in stage 4 disease, sometimes we do ipilimumab 3 milligrams per kilo versus 1 milligram per kilo. In this NADINA study, which dosing did they use?
They used the 1 milligram per kilogram dosing. And I think that fortunately we do have a clinical trial that was designed, a European trial that was designed, that compares the ipilimumab 1 mg per kg versus ipilimumab 3 mg per kg with nivolumab. And what they found was actually quite similar outcomes from an efficacy standpoint. So the response rates are just a few percentage points lower when you're using the 1 mg per kg dosing. The toxicity rates, and of course that was really the main reason for doing the study, was to understand whether or not we could reduce the toxicity or side effects by lowering the dose of Yervoy. And the dosing was, the side effects incidence was actually significantly less when we went to 1 mg per kg. So I think it would be very reasonable to go 1 mg per kg whenever feasible.
So, insurance denied the plan. The physician had actually put in the plan for SWOG because she was concerned about his kidney risks. And so insurance pushed back. They probably said, this is a stage 3 patient. Why are we doing immunotherapy up front? Why aren't we going to surgery? So there was what we call a peer-to-peer, where the physician here speaks to a physician at an insurance company who may not be an oncologist. And it was a very interesting outcome. The gentleman with the insurance company actually pushed for Nadina. And that's what we went with, which is just interesting outcome. So he got his first dose of the Ipi-Nivo on November 26th. And he got 2 cycles, 3 weeks apart, and the cancer site had flattened markedly, so it was looking really impressive. And then, of course, right before Christmas, he sent me a MyChart message that he had an early Christmas gift, that he'd been having bursts of loose stools, and he wanted us to know, and he was taking some probiotics and some Pepto over the counter, just wanted us to know. I spoke to him. Does he have any blood in the stool? No, he's staying hydrated, so what should we do? So colitis is it's not an uncommon side effect from immunotherapy. We were putting off starting prednisone, and Dr. Hanks, what's the right thing to do if you've got a patient with bursts of loose stools who is kind of hanging in there?
So if the patient was treated with a combination regimen, which of course he was.
I'm sorry, could we have a little more microphone?
Sorry about that. So with the patient with 6 to 8 loose stools per day, relative to baseline, we generally would start out with an oral prednisone dose. And I prefer to try to keep that dose as low as possible, whenever possible.
Okay. For a few minutes, we tried to manage this with Imodium and diet. Prednisone or any oral steroid can suppress the immune response, and we're trying to increase it with the immunotherapy, but we saw him in clinic 2 days later, and he still had profuse diarrhea, and his creatinine was up to 2.44. It had been 1.23, so we admitted him to the hospital. They did a CT scan, which did show colitis or inflammation of the colon, and they gave him IV steroids because oral steroids were probably going to go whooshing out with his poop. And things got better in hospital, and so they transitioned him to oral steroids. It's okay, Ms. Edmond. Transitioned him to oral steroids. So Dr. Hanks, can you tell us a little bit about this medicine called infliximab and when it's warranted for colitis?
I think whenever we have patients that are not responding the way that we would like them to oral steroids or even IV steroids, I think that we now try to transition fairly quickly to a drug like infliximab, which is a drug that inhibits an inflammatory pathway that has traditionally been used for treating inflammatory bowel disease, for example. It turns out that this drug can also be highly effective for managing colitis secondary to immunotherapy. Oftentimes patients after with just 1 dose will improve significantly over a number of hours. So this is often the preferred direction to go.
Yep. So I guess he was doing okay enough on oral steroids when he got discharged. But 9 days later, he's still having frequent loose stools, and then we did do infliximab, and with a marked improvement. So you may recall that the initial plan was to do 2 cycles of immunotherapy and go to surgery. Well, that got postponed because surgeons are not too excited to do surgery when somebody is on high-dose steroids. Dr. Dougherty, why is that, please?
It's in this case, both the steroids and the infliximab. If you're decreasing the immune response, you have a higher infection risk having surgery. So in this case, if it's not an emergent surgery and you're able to delay, it's better for a healing perspective to wait.
Okay, so surgery was scheduled for February 18th. We did rescan prior to surgery because we don't want to put somebody through a surgery when, knock on wood, there may have been disease progression elsewhere. So what do we have on the next PET scan? Myocarditis. Dr. Hanks, how often is myocarditis, which is a fancy word for inflammation of the heart, how often, if ever, is that seen with immunotherapy?
Fortunately, very infrequent.
Right. Very, very infrequently. But the PET scan said there is some uptake of the dye along the ventricle, yak, so increases the risk for cardiac abnormality. So the physician sent him off to the emergency room because we get nervous when the heart is not looking so good on a PET scan. He had a consultation with our cardiologist who has a subspecialty in oncology. And the workup, everything was very reassuring. So they do not think this was myocarditis. Okay, finally they got to surgery. And Dr. Dougherty, this was done by an ear, nose, and throat surgeon, but can you tell us a little bit about what happened here during the surgery? I know it wasn't on your watch, but.
So they did a wide local excision and a sentinel lymph node biopsy. I imagine they took 2-centimeter margins given the stage of this melanoma and the depth. The depth is usually what will determine how wide of a margin of normal tissue we take around it. So 2 centimeters is a fairly wide margin. That's the widest we would ever need to go for a melanoma. And then we inject a dye at the beginning before we take out the melanoma to find that what we call the sentinel lymph node, or that's the first 1 to usually 3 draining lymph nodes. And then we sample those and see if any cancer has spread to those lymph nodes.
So 1 lymph node was removed and it did not show any melanoma. Dr. Alrohill, it's a little difficult. Like, if there had been melanoma there, how would the report have read?
Yeah, so we can so one of the things that have evolved in what we practice is actually we're seeing treatment effect. So after a patient undergoes checkpoint inhibitor treatment or treatment targeting therapy, we can actually see the tumor dead or dying or the aftermath of death of melanocytes. So melanoma leaves a trail after it's killed. So either we see fibrosis, which is significant kind of like scar-like tissue kind of look, or we see the melanocytes dead, which is like the ghost of nuclei is basically like the death of the melanocytes, and they leave behind the melanin pigment. So we call it melanophages. If you read it in the report, that's mainly what we mean. We see the melanin pigment being deposited in the lymph node itself. So we can see if there was metastasis that got treated. In this case, this only says negative for melanoma, and there was like no signs of previous metastasis to the lymph node that responded to therapy. However, the one thing I'll mention is his excision, where we clinically saw that there was a satellite nodule from the main tumor. There was no residual satellite, so he did respond to therapy. That focus of melanoma completely regressed, and there was no residual viable disease in the excision or signs of metastasis in the sentinel lymph node.
Okay. So as far as our naked eye and technology, as far as we know, he is what we call NED, no evidence of disease, both by pathology and by scans. So Dr. Hanks, he got, permanent edema, 2 cycles of ipi/nivo. What would you do next?
At this point, based on the pathology report, we would just monitor him.
Okay.
Put him on a surveillance program and monitor him closely, physical exams, as well as imaging studies every couple of months.
Okay. Yep, so we're doing close surveillance, which, as Dr. Hanks says, we're going to do scans at least every 3 months. He's got to see dermatology for the rest of his life, and he'll have very thorough clinical appointments as well every 3 months. And if he remains free of disease, we will space that out over time. He is just really hoping to stay away from more medical specialists and avoid any more side effects and just enjoy the spring. Are there any questions? Yes, Ms. Mazurka.
Another question? This
Infliximab. It's also called Remicade. You may have heard of that. No?
I think I have heard of that. That's for inflammation that's byproduct of IBI or a dual agent, right? If you are a patient that has chronic colitis, although your treatment has been 10 years ago, but you still have the chronic colitis and all the GI issues and are full of inflammation, would that be an option to take?
So I think really having chronic colitis long-term after completing prior immunotherapy would be quite unusual, and I would be concerned about other processes that are underlying that that could be contributing to those symptoms. But depending on what that is. Yeah. Gotcha, I see. Well, these types of drugs that block TNF-alpha, which is an inflammatory cytokine that floats around in the bloodstream that contributes to the inflammation, can be very effective, and they can be used on a longer-term basis for certain patients.
Is it true or not true that anything ending in the MAB is a autoimmune suppressor?
That stands for monoclonal antibody? Yeah.
Any other questions? Mr. Cotham?
What could somebody expect to be like the time frame after they're diagnosed, they have their treatment, they have their surgery, and now they're on that, checking it every occasionally, for the side effects to actually stop and just basically the body to kind of resume its normal state? Or is that something that people deal with like consistently?
I think we've seen everything. Some of the hormonal side effects that can affect the thyroid or the adrenal gland are lifelong. But I think we've all seen patients where their GI system's just not the same, or they're just, you've heard this new normal, which is, it sounds really trite, but things can, I do think with time most people do get better and feel better, but sometimes it's just not exactly the same. Dr. Hanks?
Yeah, I think that, fortunately, the majority of patients do reach, kind of return to their baseline and normalize, so to speak. However, there are a certain subset of patients, for example, that will develop a more of a chronic inflammatory arthritis, and that's something that they have to live with, unfortunately, for really the rest of their lives. The good news is a lot of this is can also be managed with other drugs, and I think by and large patients do quite well.
Thank you.
Sure.
Any other questions? Ms. Boykin? Oh, the grading of toxicity levels?
That would be 5.
So if you had a bad reaction from autoimmune therapy and colitis and toxicity level 4, would you ever revisit that kind of treatment?
That's a great question. It really depends a lot on the circumstances surrounding that. Certainly, you have a grade 4 toxicity, we're going to be very concerned about that developing again if you're re-exposed. So in some cases, we would not want to go that direction, but it really does depend on the specifics of the circumstance.
I saw another hand. Mr. Patterson?
All I can say about it is pray more, worry less. There's only one person that can cure your cancer.
We do give him a little help, though. Miss Karen?
So I was on the Medina protocol. Do you find that, and I had those symptoms and was in the hospital for 6 days, and we couldn't get the Remicade approved. I have TRICARE. Do you find that you have difficulty getting that approved?
In my personal experience, it has not been an issue, especially if you're in the hospital setting. In the inpatient setting, I think it's actually more straightforward. Outpatient setting, that could vary, and it does depend on the insurance company. But it's unfortunate. This is broadly recognized as a treatment for this particular condition.
Mr. Best?
It works in a very different way, and I think by and large, the studies that have been done have really indicated that we are not as concerned about it having a detrimental effect on the immune response generated from the immunotherapy. I think that, in my opinion, that it is actually safe to give, as opposed to what we see with steroids, where we do have data that indicates that it could be harmful and could impair responses to immunotherapy.
Any other questions? Yes, ma'am.
So does he still have colitis at all at this point?
No, that seems to be well managed. Truth be known, he's having some arthritis symptoms now, but I didn't want to put it up there. But his colitis has resolved, yes. Yes, ma'am.
And then how does someone determine whether they're doing scans at 3 months or 6 months?
Ms. Boykin said insurance.
It
Go
really
ahead.
depends on the initial staging and how exactly, what was their tumor burden and where were they at initially in terms of their disease. So if it's a higher stage, then we're going to want to survey that patient much more frequent than if it was a lower stage. So oftentimes we settle at Q3 week imaging.
3 months.
I'm sorry, Q3 month imaging pretty commonly. So.
And is it true that if somebody's going to recur, it tends to happen in the first 2 years after diagnosis?
Yes, so I think certainly for the majority of cases, if you're going to have a recurrence, it's going to occur within the first 2 to 3 years.
But we have seen wacky things, as some of my patients can attest to. So, yes, ma'am.
So if patients don't get any treatment, so if you have a stage 4, kidney, just making something, do you have patients that make the decision not to treat because of some of the, all the side effects and things you see? And if so, what kind of outcomes do they have?
Well, right now I have a patient with, there's a spectrum of stage 4-ness. He has a nodule in his lung, but very low tumor burden. And he's really struggling with if he wants to do treatment or not, because he's very frightened about the side effects. So we will support whatever decision he makes and do close surveillance if he chooses to do observation. I've had patients in the past for various reasons that have chosen to do no treatment. And it's hard, especially when they have what we think of as a pretty daunting disease. It's hard to watch, but we support what they do. And the pace of the disease is very individual. Some people have a slow-growing disease, and some people it's taking off quite quickly. Dr. Hanks, do you want to add anything?
I think it's important to keep in mind that this is a highly treatable disease now, relatively speaking. If you're looking, at 2010 or before, the 1-year survival was roughly 23%, and now we're looking at 80%. So things have been transformed dramatically in a relatively short period of time. So I hope that we certainly support patients in their decisions, but I hope that patients in general will recognize the fact that this is highly treatable, and that in many cases it's, in my opinion, worth moving forward with treatment.
I know. Maybe one more question.
I'd just like to give everyone here your attitude and your thinking. If you love life like I do, you think positively every day you wake up. And I can't think it anymore. It's your attitude towards your illness. I am thankfully since 1990, and probably Dr. Frank, I haven't met you, but I have Dr. Galicia. But I am a
And on that note, thank you, Mrs. Edmonds. She's our ambassador for the program. We're going to invite Gabby Brennan to come up. She's with our Get Real and Heal program. Pardon me. And we're going to run a little bit late, so I hope you guys hang in there because we have some wonderful speakers coming up. And thank you to our wonderful panelists.
All right. I don't see it on there.
Like, she sent it in.
So let me go.
Do you have time to, oh, she has a flash drive.
If that's faster. Yeah.
I saw him put it in here. Okay. Before. Pardon me, Trish.
You're fine.
We'll try.
Let's see. Oh, wait, yeah, I saw it go back. If you go back, I saw it on this PC. Okay, just hit that.
Back. Okay. Oh, here. Okay. That works too.
Just don't forget your flash drive.
Okay.
And then click your forward back and then the green.
Okay. All right, I'd like to introduce myself. So my name is Gabrielle Brennan, and I am a clinical exercise physiologist and also a certified cancer exercise trainer. And I work with the UNC's Get Real and Heal program, which is located a little off of the UNC campus at Chapel Hill near the Outdoor Education Center. So we're tucked back in the woods. So I'm going to talk about exercise today. Okay, so you guys have been sitting for a while, and I'm with exercise, so you could have guessed what I'm going to do. I'm going to make us all exercise. So if everybody feels comfortable, you can get up. If you don't feel comfortable, you can stay sitting. And I was going to do squats, but because our chairs have wheels, we are not going to do squats today. So we're going to do just a nice reach up with the toe to the side, and then we're going to do nice reach up, toe to the side. So we're going to do 10 of those. Ready? Go. 1, and 1, and 2, 2, 3, 3. You guys look good. 4, 4, 5, 5, 6, 6, and 7, 7, 8. Look at all those smiles too. 9 and 10. Good. Very good job. Give you guys a hand. You can have a seat. And then, of course, when we exercise, we always have to hydrate. So if you got water near you, you might want to grab a drink quick. Now that I've kind of gotten everybody up and moving, we're going to talk a little bit about exercise today. So these are general guidelines from the American College of Sports Medicine, and these are going to also apply to those people that are affected by cancer. So for aerobic training, they would like us to get in up to 150 minutes per week. And this is going to be moderate intensity exercise. And kind of more layman's terms, because 150 is kind of a big number to try to figure out, well, how many minutes a day is that? It's going to be about 30 minutes, 5 days a week is really what they want us to be meeting for our exercise guidelines. If you are a person that you want to go faster and get it done quicker, you can. But you do have to work out a little harder. So higher intensity, so that vigorous activity, they want us to do about 75 minutes a week. Or you can kind of throw in a combo of both. For resistance training, so that's going to be our weightlifting or our resistance bands, that would be 2 to 3 days a week that they would like us to get in some resistance training so that we can build our strength with all of our major muscle groups. And then lastly is our flexibility. So stretching, making sure that we're kind of going through full ranges of motion. And they want us to do that at least 2 to 3 days per week. And this is before and after exercise. You're going to find it most effective. So
If anything, the major takeaway from this is we do not want to be sedentary. We want to increase our movement, move some type of movement. So if you can't get in 30 minutes in a day, maybe do 5, and then maybe take a break, and maybe later in the day, another 5. And moving a little bit more is going to be better than not doing anything. So Get Real and Heal is going to be a 12-week exercise program that's going to incorporate just these things I just talked about. So our cardio, our strength, our flexibility, and our balance training. We have two kind of ways that you can participate. You can participate either in person at one of our locations, or you can participate virtually through a Zoom link. And so our main location, like I mentioned, is at Chapel Hill. Last year, we just opened up a location at UNC Rex, and then just at the end of last year, we received the Duke Endowment Grant, which has allowed us to open up a couple of more locations that you can see listed there at some of the branch sites. So our mission at Get Real and Heal is to offer scalable, comprehensive, and individualized outpatient exercise to meet the wellness needs of cancer survivors of all types. And our aim is to improve physical and psychological health, improve functional capacity and overall quality of life, and to relieve symptoms and treatment side effects. And our purpose is to provide compassionate, accessible, and effective exercise programming for all North Carolina cancer survivors. So thanks to the UNC Lineberger Comprehensive Cancer Support Program, this program is completely free. So we do not take insurance, we do not take cash, we do not take anything. You come to our program, it is free. So our team, Dr. Bill Wood is going to be our director who oversees our program, and then Carly Bailey is going to be our program director. And then at the Chapel Hill location, this is going to be what our building looks like if you all have not had a chance to check it out. So we are truly in the woods. We are in a little tree house tucked back away, so it is sometimes hard to find us. But I am the program coordinator at our UNC Chapel Hill branch. And then at Rex, they are located at the UNC Rex Hospital, the Cancer Hospital right in Rex. And then Dan Riley, he's a physical therapist, and he is running that location. And then this is Guy. He was newly hired on just this past year. And so he is going to be our site coordinator at the UNC Hillsborough location, which they just actually started their classes this March. And then this is Dominic. Dominic is our remote program exercise person. And so he runs all of the online programming. And then this is just a glimpse inside our facility. So this is kind of what you would see when you walked into our building. We've got a lot of cardio equipment. We've got ellipticals, treadmills. We have a new step, which is like an elliptical, but you're sitting. We've got bikes. And of course, then we've got a strength section where you would have access to weights to use, bands to use, benches, kettlebells. And then we also have locker rooms, so if you want to come and get sweaty at the gym and then you need to dress up and go out somewhere fancy, you can come down to the locker room and shower and or change. So how could you find out more information about Get Real and Heal? We have a lot of different ways that the information should be getting out to you all. The Patient Family Resource Center should have information. You might find it through brochures, a website. You might see us in a clipping on a newspaper, TV, radio, social media, and then just, of course, by words of mouth. So the Marianne Long Patient Family Resource Center, I think a lot of you should know where that is, but I've also had some people come to me and say they are not sure where that is. So I figured I'd just kind of throw this in here. This is going to be in the main cancer hospital on the ground floor. And if you go in here, this is a huge resource of information. And there's usually somebody at the desk that's sitting there, and not only just for Get Real and Heal, but other resources throughout the hospital. They have a lot of good information there. Then brochures. Our brochures should be located in various clinics throughout the hospital. So there's an example flyer there for Rex, and then there should be one for us as well. If you Google us, you should be able to Google UNC Get Real and Heal, and you should see a little page that comes up like this, and that is going to be our web page where you can find out more about us. And then we also do have a contact us form. So if you're like, well, I did exercise today and I really want to join, you can just go online and fill out the contact us form if that's something you'd like to do. Then, of course, nowadays we've got social media. So we are on social media, primarily Facebook right now. We do also have a private Facebook page that is available. So when people do join Get Real and Heal, if you want to get all of our news and all of the stuff that's happening, you can join that private Facebook page as well. And then that's going to be what that looks like. And then, of course, then we're talking about how do you enroll. So for enrollment, we are going to require either a referral through your primary care doctor or through your oncologist, and they will know what that means. So if you are good at using your MyChart, you can message them. You can say, hey, I learned about Get Real and Heal. Could you send a referral in for me to join? And either they will do that or one of your nurses will do that. And then we will reach out to you saying, hey, we got this referral and you can come join our program. And then we will send you some intake forms to fill out. We are not directly connected via the hospital system, so we will want you to give us a little bit more information about you so we don't hurt you or injure you when exercising. And then, of course, we will do an exercise assessment. So we will kind of be able to get your baseline of where you're starting at with your current fitness level. And so what do we do at Get Real and Heal? So of course, you all will probably know exercise. But once we do that pre-assessment, it's gonna be that 12-week program that we discussed. And that's, again, including that cardio, strength, flexibility, and balance. So you're getting all in one. Like I mentioned, you know, we've got in-person or online. We are following the CDC and the UNC hospitals guidance on COVID and just being extra careful because we are working with an immunocompromised population here. So we do sanitize equipment. All of us are vaccinated for flu and COVID. So we try to be really careful. We also have small class sizes, so no more than 8 people in each class. So we are keeping that class size down as well. And then classes are typically about an hour at my Chapel Hill location. At the other locations, classes may vary depending on the availability of the people and how they're teaching their class. But for my classes, we have them either Monday, Wednesday schedule or Tuesday, Thursday schedule. And we're open from 7 in the morning until 1. And so classes are roughly about an hour. And we do individualize your class. So based off of your assessment, you get kind of more of that personalized exercise routine for you to complete during your time. And so other things that you'll have access to through participating in Get Real and Heal. So we have monthly lunch and learns, we have a Stronger Together support group, there's healing yoga, we have monthly socials, and then there's some other things that are also ongoing that will happen at different points in time in the year. So once you're finished with your 12-week session, you don't have to be done. So you can join our community. And so we have what's called our Get Real and Heal community, where after you graduate from the program, you can decide to stick around. And we have what's called open gyms on Friday. And so you can kind of pop in and get to do the workout of the day that they have on the board. We do ask that you sign up just kind of so we can make sure that we're still keeping the class sizes smaller. But you can take advantage of all of our programming just the same as when you started. So you'll have access to the lunch and learns and all the extra things that we do as well. And so speaking of lunch and learns, we do actually have a lunch and learn coming up tomorrow. We have Amy Vandemark, who is a social worker. She's going to be talking to us about forest bathing. And so that is tomorrow at 2. We have an online, that happens online via a Zoom link. But we do have the second Tuesdays of the month. We'll always have a different speaker. So you can see we've got a dental student coming up. We've got a physical therapist talking about lymphedema and cording. So lots of different opportunities to talk to professionals in their areas to get some advice. Then Stronger Together is, like I mentioned, that support group where we talk a little bit about cancer treatments and how it has affected participants' health and well-being. And this is typically about an hour-and-a-half session, and that happens the third Thursdays of the month from 6:30 to 8:30. And this we offer both in person and online. So you could come in person, or you could just say, I'm not driving, and you can just sit back and kick back and do it online. And then we have lastly healing yoga. And so healing yoga, Kathy Thurber runs this. She is a registered yoga therapist and also a breast cancer survivor herself. And so she runs about an hour and a half sessions. Hers are typically mostly online, but she does offer an in-person class on Wednesdays. That's at the St. Thomas More Church. And then, of course, our socials. So I like to do things not cancer and not exercise, just fun. And so we do try to kind of find a fun thing to do. We try to make them free if we can, because I know we don't try to do anything with cost, but sometimes there is a low fee depending upon what it is. It's not required that you have to go to these things, but they're just fun to do. So you can kind of see snippets here from different things that we've done throughout the years. We did Durham Bulls games, we've went out to breakfast, we've did some training for the Fleet Feet 4-miler, we have picnics, we've even went to the UNC women's basketball games. So just fun things to do to take our minds off of exercise and cancer. And so then these are just kind of, and I'm not going to read each one of these, but these are just kind of some feedback that we have gotten throughout the years from people participating in Get Real and Heal, and kind of how they felt that this helped them. My favorite one is the last one. And they talked about Get Real and Heal being kind of a lifesaver, and people, they were able to take back control of their body. That they felt that cancer, chemo, and radiation had been controlling for many months. So they felt like it was something that they were doing for them. And that is my presentation. Any questions?
That was awesome. Thank you.
Oh, you got me.
Thank you so much. That was awesome. All right. Next, we're going to have probably my, I don't know, I think it's one of the most important parts of our day, and that's when we have some patients and one caregiver come up and share their stories. Just as a coincidence, they happen to all be women this time, but I'd like to invite up the 4 patients and one caregiver and come up front. So we all met, the 5 of us met, or 6 of us met on Zoom a couple weeks ago so we could get to know each other, and I kind of told them topics that I might be asking them about, and I just wanted to thank them all for coming and being willing to share. So if each of you can introduce yourself and maybe say a little bit about what brings you here today and what happened.
Sure. My name is Karen Lindell. I live in Pinehurst. Had a mole in the middle of my back last year. We went from 0 to 60. It's not something I normally saw. But ultimately saw Dr. Olia, and we determined I had malignant melanoma stage 3. So I did the Nandina protocol. That's how I met Paula with Dr. Moskos, and that's why I'm here, thankfully.
My name is Sherry Cotham, and I'm a caregiver. My husband was diagnosed with stage 3 melanoma last year, and he's the one that shaved off the mole, and it grew, and you know, we just went through a heck of a time trying to get to the right place. Once we got here, it was amazing. So it's important to be an advocate for them.
Hey, I'm Kristen Vernon. I'm from Saintford. What's that?
Hi, Kristen.
Hi. And I was diagnosed with stage 3C melanoma last May, and then it quickly kind of progressed, and now it's stage 4. Can y'all hear me? Sorry. And I started off doing immunotherapy. It didn't really work, and so right now I'm taking Mektovi and Braftovi, and I'm waiting for a clinical trial to open up. So hopefully it'll open up sooner rather than later. But right now, I seem to be, knock on wood, doing okay with the 2 chemo pills. Oh, sorry. We've got lots over here.
I'm Christy Fuss. I live near Fayetteville. I won't tell you the little town because you wouldn't know where it was anyway. But I was diagnosed with melanoma on my ear in February, I believe, of 2022. And they said there's just I think 2 to 5% chance that it would come back, and we don't need to do scans or anything like that. Well, November of 2023 or October of 2023, I found a big nodule in my hip, and it took till December of that year to determine that that was also melanoma. I had that removed and was referred to Dr. Moskos, and then found out in April of last year that really I had it everywhere, including my heart. And I'd always ask that question, no, people don't get cancer on their heart, but I got the call from Paula, it's on your heart. And so I thought that was it, but God had another plan. So praise God that I'm here.
Hi, my name is Kate Luttrell. I was diagnosed with a melanoma tumor on my foot in March of 2022, had surgery in April. Thought all was well until October of 23, when I discovered a bump on my foot and moved to stage 3. Started immunotherapy, went through all the ones listed that we talked about today, moved to stage 4, and ultimately I was the first TILS patient here at UNC. So doing well now.
So a lot of my patients remember exactly where and when they were when that dermatologist called and said melanoma. They'll tell me, I was in Walmart in aisle whatever and I got this call, or I knew it was bad when it was a Sunday night and the doctor was calling. I didn't know if anybody wanted to share kind of their first reaction when they got the news.
Well, whenever I got the news about my ear, I was at home alone, and it kind of sucked the wind right out of me. I had to take some deep breaths and pray, but my main concern at that point was my husband. And so I think probably most of these ladies can relate to that you always care about your loved ones, because I think it's harder on them in many ways than it is on the patient themselves.
It was, I remember the time and everything, 7:55 on a Monday morning, July 8th. And we received the call from the primary care doctor who said, you have melanoma, I'm really sorry. And, you know, we talked about where we were going to go and what we were going to do, and we got right into UNC. We were just coming off of Sean having a thoracic aortic aneurysm, so he had a repair done here at UNC, so we were pretty adamant that we wanted to keep it at UNC, and we were lucky enough to be gifted with that. So Dr. Moskos and Dr. Myers and Paula, she sets the bar really high, because if it wasn't for her, I probably would have gone crazy.
So technology is a pretty amazing thing. I saw my diagnosis in my chart. So I got in there, I knew I was waiting for pathology, and I saw that I had basal cell as well as malignant melanoma. I knew enough, and thank you for your presentation today, because it helped me understand. I knew it was aggressive, but So that's how I found out. And then I had the amazing opportunity to work with Kim back there. And we had a long journey on trying to get the referrals. So that's how I came into this. Dermatology, sent it to my primary care, and then, but I knew it's just figuring out kind of where to go and when to get started.
I don't think I mentioned the first time that my melanoma is on my scalp. And so I actually have been doing mole mapping at UNC since 2010. And actually, I was at a wedding in Charleston in 2018, and I was getting my hair done by this lady, and she's like, "What's on your head?" And I'm like, "I don't know. What is it?" So anyway, I called immediately here to get it biopsied, and in 2018, it came back as a compound nevus. So at that time, I think that's a fancy name for a mole. Is that right? So anyway, we've known about it, but then I just noticed probably spring of 23 that it was itching and burning, and I just asked to get it rebiopsied again, and it came back as melanoma. And it was, I think I had 2 lymph nodes taken out, and it was in one of the lymph nodes. So just be extra diligent about your scalp when you go to your dermatologist, because that, obviously that's a part of the body that you can't see. So yeah.
I knew in my dermatologist's office, I've been for a decade doing 6-month skin scans with her, and she's removed all sorts of moles, and the routine's always the same. You know, this is probably nothing, but we're gonna take it and send it in. And this time she looked at it and she said, "Oh, we're taking that." And I thought, okay, bingo. This time it's going to be something. And so when she called a couple weeks later with the diagnosis, she called on a weekend, which is also a bad sign. And I wasn't really surprised. But
So what have you all found to be the most helpful in your cancer care, either from family or friends or providers? And what has not been helpful?
I will tell you that the very best advice that I was given came from my brother-in-law, who underwent stem cell treatment for a brain tumor at the height of the pandemic. And what he told me is, trust your medical team. They've got this. They know what they're doing. Don't spend your time and energy trying to second guess or Dr. Google them or figure out whether this is the right way forward. They have your back. Trust that. And that was absolutely the best advice that I got at the very start of this program. And it's proven true. The UNC team here has been phenomenal. And I feel blessed to have ended up here and to have the care team that I have.
The most helpful thing to me is my faith in Christ, because whether I'm here or God chooses to take me home, I have peace. And so I've had peace all through the journey. And I'm just so thankful for that. And I just want to echo what my friend said here about the care team. The word team is what describes UNC. I think is probably different than most oncology offices. To have a team and to know somebody like Paula, I feel like we should give Paula a round of applause. Because I know she's so important to that care team, and to the many times that you've gotten a call from Paula if you're a patient, you know that she really cares, and I really have appreciated that.
Thank you.
I would second that. The team here is amazing, and the coordination of care between all the providers is amazing. And, I don't hesitate, I'm sure you realize this, to hop on my chart any day, any night with any question. And I know that at some point it's going to be answered. So I have faith that everyone on the team just really has our back. And, you know, they're very good about saying, okay, this is what we're going to try. And, you know, just don't give up. Like, you know, every day there's new treatments, there's new things coming out. And so you just have to have hope and believe in that. So that's just very powerful to hear that and have people to really, you know, remind you of that.
I'm gonna cry. I'm sorry. I saw Dr. Aaliyah on June 5th. I'm so sorry. I'm done. I thought, and I went by myself. I told my husband, "Don't worry, I'm good." I thought, you know, we were just gonna consult, have that mole removed. I was almost out the door, and he said, "Let's check under your arms." And he did. And he told my husband and I one time, he said, "I get this great, honestly." And I truly believe that, because if it had not been for him and the team, we were off to the races after that. He said, "You're a stage 3. And it kind of took my breath away. And he put his hand on my shoulder and he said, "You are very, very lucky that you're having this diagnosis today and not 10 years ago." And he said, "And we're going to be okay. We're going to get through this." So I appreciated him, because after that, I was with you and Dr. Moscos, and again, we were off to the races. So I appreciate you, Dr. Aaliyah, and I appreciate your team for getting us through this.
I think what I'm most thankful for is the team at UNC, because they didn't hesitate. They just got Sean right in. They took care of him. I made sure that his meds were given to him in the correct amounts and all of that stuff, but there was a lot of changes, a lot of going to the emergency room, and you know, it's just, I'm just grateful that we chose to stay in-house with the doctors here at UNC, because it just really made all the difference in the world.
Mrs. Cotham, so as a spouse, you know, it's a hard balance to, you know, hover, but not, you know, not too much, but kind of peek around the corner. Is he okay? Like, what's been the most difficult, you know, as a spouse or caregiver going through something like this?
Getting it wrong.
Like that responsibility about getting it, like you're in charge of being his.
Getting it wrong.
Just for the record, she got it right every time. She was awesome. So.
I didn't feel like I got it right every time. Just a lot of perseverance and never giving up, and we fought like cats and dogs. I didn't understand why he didn't remember things. I didn't understand why he wanted to combine multiple doctor's appointments. I didn't understand, and that's where I think I got it wrong. You just want to make sure that they're okay. You want to make sure they're fed. You want to make sure you get their meds right. You want to make sure everything is okay, because they're going through so much that they have no control over. None of us had control. You know, as much as you feel like you had control, you do not have control. So giving that up, probably having no control was very difficult.
You did a good job, by the way.
Thanks. Thanks, babe. I ain't done yet.
Ms. Latrell, I'm going to put you on the spot, because I know people are very, very interested and excited about this TIL adoptive therapy, and you were the first one to be brave enough to do it with us at UNC. Dr. Clicchio talked about it a little bit. Can you just share how challenging that experience was for you?
Well, it's you go into the hospital for a couple weeks, or 3 weeks now, I guess. The first couple days they do chemotherapy, which has its own side effects, none of which are pleasant. And then the next 3 they do a lower level, so you start to feel better. So the first 2 days are hell, next 3 days are all right. Then they infuse the cells. Now the cells are frozen. I have never been so cold in my entire life. And honest to God, this sticks with me more than anything else, just how cold I was. Then you go, and that all takes place on the bone marrow transplant unit. And then you go into medical ICU, and they start the IL-2. I don't have much memory of the IL-2. It was rough. But we came out the other side, and now I think people are staying longer. I actually went home after that, but my platelets and other things bottomed out, so I was back in the hospital every single day, which is, I think, led the program to decide to hang on to people longer than they hung on to me. The hard thing was I guess I thought that once I went through it, we'd see instantaneous results. Either it cured me, it shrunk the tumors, or nothing happened. And those were the 3 possible outcomes. And right afterwards, the tumors seemed to me to be getting bigger. So I had an inflammatory response, which turns out to be normal. But the treatment's actually very long-term. I had this in October. We've now gone through 3 sets of scans where my tumors are still shrinking. My next set will be in June, but nothing new has started to grow, and everything's smaller. So that's a great outcome. It was totally worth the 2 weeks in the hospital, 3 weeks of really being unable to, just being bedbound, I guess. But it was it would, if I had to make the decision again, I would do it again. Said it.
Thank you. That was beautiful. Thank you. We were very honored that she put trust in us to take this big leap of faith. We've since had 3 or 4 other patients go through it, and yeah, it's a lot. But if it works, it's supposed to be a durable result. Is there anything that we as a team here or at UNC did that was not helpful or that we can improve upon? It's the emergency room discussion.
Yes. Here it comes. So I was on Nandina, and I obviously had the results, or the inflammatory response and the colitis 30 times a day. Did not want to come back to the hospital. They convinced me to come. And I think I spent 36 hours in the ED before I was admitted to the unit. And I understand that that's a problem nationwide with our emergency departments, but and there are patients, I'm sure, oncology patients far sicker than I am. But 36 hours in that environment was rough. So if there's anything that could be done future state about a separate, D-zone, someplace for your oncology patients prior to going up, I think that would be huge, and that would be beneficial.
I second the motion. Yeah, because we had that same experience, except I was so sick and I wasn't willing to stay, so I said, take the IV out, I got to go home. We live an hour and a half away, hour and 45 minutes, and just sitting there, being in that condition, I couldn't do it. And I did come back later in the week and got what was that drug?
infliximab?
Yes, I did get that drug. But I could have gotten it in the hospital had things moved along like they should have. So, yes, definitely, if they could improve that, that would be wonderful.
Does anybody from our audience want to share or ask any questions? Mr. Cotham?
I just love to talk, so you'll have to forgive me. I just want to say, well, first off, thank you, because Paula, she's like Top Gun, she's on it. They ain't getting away. You know, every time Sherry had a question or a concern, whether it was valid, not valid,
It's all
really
the time.
all over it. And she called back and she emailed right away, so thank you for that.
You're welcome.
But I will just say, there are things that are gonna happen when you go through this treatment. You don't come out the other side the same. You're not the same person. Emotionally, physically, there's some side effects that happen that are, it's just now part of your life. So, this team, the support that they give because of that, like we saw all these people come up and talk about programs, you know, there's really not too many other programs, I think, that have that much support to it. And so, just appreciate you guys, thank you.
Thank you. Well, we could talk for a lot longer, but we have one more speaker that some of you may have heard of. Trish, do you want to introduce this next guy that people have been talking about? No introduction. Thank you so much.
Thank you, guys.
All right, come on up, Dr. Lilla. So, Dr. Lilla has started here many years ago. His hair was not as gray as it is now. He's gone through many years of melanoma, and he's going to give his rendition of where he started to where we are now, right?
I am.
Okay.
Thanks, Trish. Thanks, Paula. So I am not sure why I always agree to talk after the patients. I'm not sure Paula does that to me to make sure she's respectful of my day or what, but I just want to acknowledge the work that Paula Landman and Trish Long do for this every single year because it's incredible. Can you join me in So they kind of play Mutt and Jeff on this one. One says, oh, she does all the work, and the other one says, oh, she does most of the work. But I think it's a really unique pairing of the two women that we actually have at our disposal for the entire program. And so I just want everyone to realize that whatever I'm about to say, there's got to be a team with us. And that, I hope, is the theme you've heard all day. Yes, I'm old. I'm 61 years old. And for those of you that may or may not realize, there have been some incredible ups and downs in the care of the melanoma patient. And I'm just going to walk you through my personal journey, okay? Because I think this cartoon depicts it the best. You'll see some things where I've actually written to counteract what I said previously in manuscripts. And that's the way that this field goes. You've already heard some tips. You saw in a tumor board of what some of my punchlines are going to be. You don't realize it, but there's not one, but two TILS patients have been meandering through the conference today, which is the most exciting thing that we're doing. And so there's lots of things, but I think the context of where we were and how we've gotten here is really important for people. So I was a resident from 1990 to 1995, and Ms. Long, I do not need to hear what grade you were in at that point in life.
High school. That's my era.
I know. Mrs. Edmonds, and please make sure your phone goes off while I'm talking. I cannot wait for that. Yeah, I want it. I just want it to go off, okay? So here's the interesting thing. For all of you, I took care of one melanoma patient as a resident. I took care of it with that man, Dr. Kim Hamelberg. It was on the left upper back. It was a Clark level 4. We did 2 centimeter margin excision. I said, now what are we going to do for the patient? And he looked at me like, nothing. We have no FDA approved drug that actually works. We have nothing to give. And you see, if you pull out one of my archaic textbooks off of my shelves, median survival for a stage 4 metastatic melanoma patient, 6 to 8 months. That's it. Okay? So I go to clearly a hotbed of melanoma. I trained under Dr. Don Morton. For anyone who's been on Dr. Google, you'll see his name over and over and over. And unfortunately, he was the king of sentinel node, which is great, but also the king of failed immunotherapy after immunotherapy after immunotherapy trial. So we all have to remember that we're benefiting on the backs of the brave patients that went on to clinical trials back in the 70s, the 80s, the 90s, when we didn't have anything. Nothing passed muster. Did I learn how to do the sentinel node with Don Morton? Absolutely. Is he the godfather and the pioneer of sentinel node? Absolutely. Does Rami and his group look at sentinel nodes exhaustively? Absolutely. That's where it starts. But still, as I told you, we didn't have any other therapy. So we're diagnosing people more accurately because we have a sentinel node and we can tell the stage, but we don't have anything for them to go on. We used to pluck out the sentinel node. Rami or one of his team would say, oh, you have micrometastatic disease in the sentinel node. We'd take the patient back to the operating room for a complete lymph node dissection. Remove all the lymph nodes in the neck, remove all the lymph nodes in the armpit, remove all the lymph nodes in the groin or whatever the basin was. But guess what? We were wrong. Doing the completion lymph node dissection for those patients that don't have demonstrated micrometastatic disease remaining have no survival benefit. So for those of you that wonder why Trish or why Paula keep bringing you back for every 3-month ultrasounds, in addition to all those PET scans, it's because we have an international trial, the US and Australia, and we have a second German trial that shows that ultrasound surveillance of the basin, as opposed to immediate surgery, has identical outcomes. Right? So that's why you're going to see, and people struggle sometimes to say, well, wait, I'm getting a PET scan. PET scans are good to about 5 to 6 millimeters. Lauren Burke and her team with the ultrasound can find a thickening of a cortex, can find loss of fatty hyaline. And I'm just giving you buzzwords that you may see in my chart, because remember, Trish, Paula, Brent, Rami, we don't control when it goes to your my chart. We can't. We're forbidden from stopping anything. So there's lots of things, but that ultrasound probe is much more specific when it's targeted to an area. And that's why we can save the patients having to go through those much bigger operations if there's nothing there. But here's the game changer, right? And this is absolutely, positively what's changed our world. So for those of you that come in and talk to me, I specifically ask you not to read anything prior to 2011. I then ask, please really don't read anything prior to about 12 to 18 months from the time you see us, because that's how fast our field has changed. From 2011 to 2025, this has been an absolute positive whirlwind. These are the people we see. These are the people we saw back in the 90s when I started fellowship. These are the people that we still see today. And so for some of you in this audience, you may be going, hey, denial is incredibly powerful. And don't let anyone tell you anything different. The number of exotic headdresses, bandages, hide it type garments we've seen, it's amazing what the human being can do to deny, okay? All these people had either locally advanced stage 4 disease. The gentleman in the upper left, actually those are distant nodules from a stage 4 disease. So again, here's the history for you. This is not sugarcoating how poor this was. Dacarbazine, FDA approved drug based on feeling. There's no level 1 evidence that dacarbazine has any overall survival benefit. Has a response rate, but no, so anyone who took DTIC or knows anything, interleukin-2 has a small complete response rate. Interferon alpha 2b was like sugar water. You gave it to the patients, they felt miserable, but there's no overall survival advantage. Again, context and rooting us on the ground of why we're here in this era of what we are for the last 14 years. They used to say, if the surgeon and the dermatologist can't cut it out, send the patient to Dr. Hanks. Hopefully he has a trial you can go on. But there was no prospective randomized trial that showed a benefit. So a lot of times patients would come to me or my colleagues and we are doing some major multi-organ resections, multi-basin resections, because we didn't have anything else. Okay? And you heard from Kristen how that has flipped, and I'm going to give it to you again. But I've written many things about complete metastasectomies. And then the world spins, and we continue to say, wait a second, maybe that's not the right thing to do these big, major operations when we're starting now in 2011 and 2012 to start accumulating effective agents. We've talked about it, we danced around it, but the checkpoint inhibitors are what makes a lot of this go round, right? And you heard earlier about IPI, right? IPI blocks the CTLA-4 inhibitor. So, right, I always think of this as a brake on the brake. So that means these cells just proliferate. The PD-1, the Pembro and the Nivo antibody here, this then allows the white cell to recognize the tumor cell and kill it, okay? If you had any cartoon that you wanted on your phone, that's the one. Because this is what's the story of how we got our beginnings of being able to advance. Here's the basic trial, and I don't know if Brent was there. This was presented at ASCO, which is a huge meeting of all oncology, dominated by medical oncologists, surgical oncologists go, radiation oncologists. It was a standing room only presentation to see a survival benefit of 4 months. Think about that. A survival benefit going from what I've showed you previously, right? That my archaic textbooks, 6 months, same thing. Heavily pretreated patients, and this starts everything. Fast forward now we have, I've talked to you, you've heard about IPI, you've heard about Nevo. This is a slightly outdated slide because now the overall survival at 7.5 years is 48%. But this bottom curve in treatment naive patients, meaning they haven't received any treatment, is the IPI. The blue line is the PD-1 inhibitor, or Nevo in this case. This is the combo. So we now know that combo is superior, as Dr. Hanks was saying. Combo is superior in efficacy, provided we can get the patients through, right? So you still have a delta between these two curves, so you have to now weigh the risk-benefit of being able to get the patient through. Again, these are for stage 4 patients, treatment naive, but Checkmate 067 is just a game changer. So now what do we do? Now we have the surgeons wondering, what the heck do I do now? I got this patient with bulky disease, I got a lot of things going on, what do I do? Surgeons are so used at this time to doing these big operations. You don't have to raise your hand in here, but several of you have had major operations prior to the immunotherapy era. And trying then to re-educate people of, oh yeah, that's what I said then. Wait, this is what we're gonna do now. It's a completely different mindset. So the concept now is, and this is just a basic schema of neoadjuvant, right? You have a patient who has stage 3 disease, and instead of the surgeon taking the patient to the OR, we lead with whatever drug therapy you want, right? SWOG 1801 had a single agent, Nadina has dual agent, how many cycles, how many weeks you wait, we can still discuss that a little bit. But you're gonna go to your surgery. And now we have a really powerful pathologic specimen from Rami. What's in or not in, or how little or how much is in that surgical specimen means a ton. And again, we've talked about these, and these are the backbones for what we do. Single agent, PD-1 inhibitor, dual agents, intralesional TVEC, who we've talked about previously, and these all have event-free survival that is going to lead to an overall survival. But the trials are just not mature enough to have an overall survival benefit unless Brent has inside information and he knows that one of them is going to be published. But event-free survival has been published. We're still waiting on overall survival benefit. Okay? These are the game changers. These are the ones that make some of you in the room go, David, that's not what you said 10 years ago. And I know I didn't. That's why this is the roller coaster talk. Because this is a complete flip. This is coming in and saying, okay, we got options. Let's go through the options. If any of you have read my notes about you, I say you're going to go see Dr. Hanks. I've discussed all 3 of these options. He's going to talk you through which one he thinks is the best for you, and then I'll see you back. Then we'll talk about a surgery, and hopefully the magnitude of the surgery is much smaller. Okay? Now what? Not everyone beats it with these drugs. You can make a great argument, or you should have put your hand up and said, David, what are you and Brent doing about these 51%? That's an entirely fair question, right? Immunotherapy resistance is an extremely hot topic, and it's a focus of what Brent's lab is looking at, trying to figure out pathways, markers, signals that can say to us, you better be worried. Okay? So I know you've heard a little bit about it. Now, there was one step that wasn't told to you guys. At some point, I got to harvest tumor, right? I got to harvest tumor in a sterile fashion, roughly 4 by 4 centimeters, put it into the magic potion from the company, because we're not allowed to know what's in the potion, send it to them. Hopefully we get the email that says the cells grew, patient comes back, lymphodepleted, give back the cells. And that's the first time I've heard how cold they are, so thank you for telling me that, okay? This is the new, right? And so if you'll notice, a lot of what I've said is about our program, and I really haven't said anything about any other facility in North Carolina or South Carolina. She was patient 1 in North Carolina and South Carolina. Yep. So you think of all the other facilities in North Carolina and South Carolina, we were the first. And I'll just leave it at that, okay? This is the exciting thing. This is really exciting. So we actually have hope for the immunotherapy resistant patients even before talking about a clinical trial. They could go on a clinical trial, but we can still harvest tumor, send it to the company, hopefully they grow so that we can infuse it back into the patients, okay? So again, this is always a great day for me. I am not upset that I'm the last speaker. It does not bother me at all. So once again, thank you guys so much, and I hope that that talk gives you context of the journey of where I've been for the last 26 and a half years, because the patients have gone through this journey with me. So thank you very much, and I'm happy to take any questions. Yes? Right, so then, and I didn't put this in a slide, but people will tell me, and I have to keep remembering the right fingers, we are now up to 14 FDA-approved drugs for stage 3 or stage 4 metastatic melanoma patients, right? 14. I'm not saying everyone's eligible for all of them. 14, and if my math serves, that's 14 years, okay? Other questions, comments? Yes?
Has the current political situation affected cancer research?
Yeah, so this is a hard one, right? So it depends how you're funded, right? So, and it depends on what Washington wants to fund. So I have a friend whose wife works in long COVID. They got word 10 days ago all long COVID projects are being funded because this is a national problem and that we're at the cutting edge of trying to help figure out what to do for those people. We haven't heard any word yet of where they're going to dice it up at UNC for cancer. So I think your point's very well taken. I just don't know where that's going. Fast forward to me, I'm 99% philanthropy funded. So I don't have any worry. In fact, I have to tell my research associates to relax because I'm in no danger of my funding being pulled because of how different I am in the funding. So I think it's an entirely fair question. I think it's dynamic, and I don't know where it's going to come down, and I don't know where the whole indirect, and so for those of you that may not realize, the whole buzz about the academic medical centers being bloated is because of the indirect costs. Well, the indirect costs pay for the toilet paper, pay for the lights, pay for the janitorial services, pay for people that aren't in the grants. And so it's hard sometimes for John Q. Public to look at Duke is at 61%, UNC is at 55%. Well, that's a lot of people to lay off if the indirects go away completely. So wherever that is, so hopefully that's not too long-winded answer, but gives you more of a how this is shaping up, and it's literally a week-by-week thing, okay? Yep.
On the new therapy that UNC was the first to administer successfully.
In these two states.
In these two states.
Yeah, I just want to be careful about that because other people have done it elsewhere, but I'm very proud, and we are very proud that we were the first in North Carolina, South Carolina.
And you should be. How is that therapy effective for brain mets, or is it?
We don't know yet. And the problem is that you might be able to get a patient on with brain mets, but the patient with brain mets has so many other issues that you really have to stabilize the brain mets before you're going to put someone into lymphodepletion and give back TIL cells. So totally fair question. I don't think any of us are ready to answer that yet for brain mets that aren't stable yet. Okay?
When do you think we would get there?
Well, I think that's why we have Brent Hanks in the room. That's why we have Sergio Moscos. That we're trying, right? Because if we're honest about it, that 51%, the overwhelming majority that takes the 51% are brain mets. The other are liver mets. So not that other stuff can't do it, but brain mets and liver mets dominate that 51%. Anything else? Paul, have I covered what you wanted? Thanks, Paul. Trish, we good? Oh, that was lovely.
Thank you all for coming today and for trusting your care with us. We're very honored and privileged to be part of your lives. If you could fill out the surveys and drop them off to me, that would be really helpful. And safe travels and have a lovely day.